Hi, Gochi. So we start exactly at 6:02. 6:02 for me.
Hey, can we check Dr. Ugochi's audio?
Gochi, can you be heard?
Yeah, but I'm moving to a better place.
Okay.
Okay, I just wanted to make sure. Yeah, it
Yeah.
didn't sound
I want
digitized.
to be sure I can share. Okay, I can share.
Yeah. And we can hear you well. So shall we start? Okay, so good evening, everybody. It is a cold and rainy Saturday evening in Nairobi, where I am. It might be summer where you are, and it might be morning or it might be afternoon because we're across continents. My name is Khalida Soki. I'm a nephrologist in Nairobi, and I am the Deputy Secretary General of the African Association of Nephrology. Welcome to this symposium, an onconephrology symposium hosted by the African Association of Nephrology alongside with the American Society of Onconephrology. We're so happy to have everybody on board, and we've been trying to organize this symposium for some time on a topic that we're so excited on. So I'm just so happy to finally get it going. I would like to introduce my co-moderator for this session, that is Professor Pooja Amarapurkar. Pooja, I think, is just one of the nicest people I have met, and an assistant professor in medicine at the University of Pittsburgh, Department of Medicine, Renal and Electrolyte Division. I think, Pooja, one of your pet projects is just looking into things that are really practical and useful towards the daily life, improving the daily life of our patients. Pooja is a clinical educator. She loves taking care of her patients and helping them along their journey. Looking at her scholarly interests in onconephrology and sickle cell-related kidney disease. Pooja, we're so happy to have you on board and lovely to get to know you. I'm going to hand over to you right now and allow you to introduce our first speaker, and that is Professor Biru. Go ahead.
Awesome. Thank you so much for the extremely kind introduction, Khalida. It is truly an honor to know you and connect with you. And thank you for the extremely kind introduction. So today we have a great speaker lineup. We have some people from the ASON side and some people from the AFRAN side. And I think it's going to be a great collaboration and discussion across the continents to understand how things are done similarly or differently, and, just kind of have a very nice clinical conversation. So our first speaker for the evening or the day today is Dr. Biru Workini. I'm sorry if I did not say the last name correctly. I apologize. But he's a professor at the University of Texas, MD Anderson Cancer Center. He's a great person, apart from being a phenomenal physician, and also the one of the pioneers of onconephrology and ASON. Also, he was the president of the society last year. His educational background was his training was at University of Texas, MD Anderson Cancer Center, and then his fellowship was at Stanford University. He's held several leadership roles, including the dialysis director, and he's a primary clinical and educational interest lies in electrolyte disorders in cancer patients. It's a very critical aspect of caring for these patients. And he really works hard in this niche, has had several publications which have been outstanding and really very key to this field of onconephrology. And he likes to understand the complex relationship between cancer and electrolyte imbalances. And his aim is to ultimately improve the quality of care for his patients and addressing this unique population. Besides this, I think he's a great mentor for all young faculty, and has a great vision. So without further ado, he's going to talk to us about onconephrology.
Hey, Pooja, that was a great introduction. Far too kind. Appreciate it. And it's an honor to address this audience, this joint symposium with AFRAN. It's like Khalida mentioned, a long time coming, and something beautiful. She said that it's cold and rainy in Nairobi, and in Houston, Texas, where I am, it's hot and humid. No surprise, and so anyway, it's really neat that we can connect from all over the globe. I'm gonna share my slides, and hopefully no glitches will occur. Okay. And I'm hoping that it is projecting. And someone holler if it is not. So looks good.
Looking great.
Okay. All right. So so all my talks I give to medical students, to house staff, my fellows, my colleagues, I always have some rhetorical device or some back and forth, make it interactive. So if you can make use of the chat, maybe Khalida can help monitor that. And if you have any questions, please chime in, and I'm happy to stop the talk and address the question at the time or at the end. So I just encourage you to use the chat button. So I was asked to give an introduction to onconephrology. So onconephrology in 2024, we could do a sort of a survey, but I thought that the that perhaps talking about checkpoint inhibitors, which really put onconephrology on the map, would be a great way to introduce onconephrology and why it's such a necessary discipline or subdiscipline. You know, we've lost some poetry in medicine over the years where you know, you don't have articles in New England Journal or Jason or any of our journals entitled "The Great Masquerader." But back 40, 50 years ago, we had those kind of articles. Maybe we didn't know as much, so we had to inject a little bit more poetry. So just rhetorically, I want you to guys think, to think about what the authors were referring to when they labeled one disease the Great Masquerader. So I'll just pause, and maybe Pooja or Khalida can chime in if you can give me an answer real quick. The Great Masquerader, syphilis, right? Secondary syphilis, because it can present in so many different ways, and so and it often would confuse clinicians, and so it's also been attributed to lupus, because lupus, as you know, is very difficult to have a universal diagnosis. You can have a patient with 4 different diagnoses, but lupus, for example, will tie it all up. And also HIV, has been referred to as the Great Masquerader, because it can present in so many different ways. So I want to have a new entry into the Great Masquerader club, and that's immune checkpoint inhibitors. So our objectives today are to describe the historical progression and the foundational research leading to the development of checkpoint inhibitors. So you'll hear me say checkpoint inhibitors, ICIs, or CPIs. They all mean the same thing: immune checkpoint inhibitors or checkpoint inhibitor CPI. We'll talk about the mechanism of action and its toxicities, and we have a later talk about drug toxicity in general. So hopefully I don't step on that speaker's foot, but we'll just focus our energy and focus on ICI therapy, and then we'll talk about a general approach to managing ICI toxicity. Okay, so let's start with a case. So first case is a 73-year-old Asian male with hematuria. He had a left nephrouterectomy for papillary transitional cell carcinoma of the kidney. Due to disease progression, he was started on anti-metabolic therapy and referred to MD Anderson. So he was at MD Anderson treated with nivolumab and ipilimumab. There's a lot of tongue gymnastics required for these, so you'll often hear providers refer to this as Nivo and Ipi for short. So you might hear me say the same thing. This refers to nivolumab and ipilimumab. Other than antihypertensive, there's no other medicines. And after starting therapy, he popped up to a local ER with some back pain and some discolored urine. And the urine is what you see. So it's dark colored. You really can't see through it. Doesn't really look like normal urine. He was started on empiric antibiotics for a possible UTI and told, pat on the back, drink more water, and went out the door. Several weeks later, he returned to the emergency department with some weakness. This is an actual case with he just couldn't walk anymore. He had difficulty eating. He was in renal failure with some acidosis, hyperkalemia, and you can see the labs are just consistent with AKI. And so again, I want you guys to think of the answer. Maybe put it in the chat, or if one of the moderators want to chime in. Which of the following medical conditions is the primary cause of the AKI? Is it a UTI? Is it ICI-induced nephritis? Is it ICI-induced rhabdo? Or is it acute tubular necrosis? And so there is a best answer. So as you guys think of it, we'll return back to his labs. He is at MD Anderson, and we have our antennas up for a lot of things at MD Anderson, at any center that deals with patients with cancer receiving immunotherapy. And so someone thought to check a CK, and it was really high. So it was 18,000. So he had rhabdomyolysis the whole time. He received IV fluids, methylprednisone, and later infliximab with return of his serum creatinine back to baseline. So fortunately, rhabdo is rare in CPI treated patients, but these are some cases that you can refer to. I just, for the benefit of the audience, included a whole bunch of case reports of patients with polymyositis, dermatomyositis, and including with anti-striatal muscle antibody, and clearly induced by the checkpoint inhibitor. And so I think that is a great introduction to why we need to know about checkpoint inhibitors and the various ways it can present in our patients, at least the toxicity. So over the years, there have been a number of anti-cancer agents. You can read for yourself, alkylating agents, so on and so forth, up to this bullet points where it says hormone therapies. And during my career, the targeted therapies have been developed. These are the tyrosine kinase inhibitors, anti-VEGF antibodies directed towards tumor antigens, and then immunotherapies, which we'll talk about in this talk. Also cellular therapies, CAR T cells, also NK cells, which I didn't list, and then nanobodies. Nanobodies is always fun because obviously it refers to like small antibodies, but these are derived from camels, from llamas, from salamanders, sharks, and they can be engineered to approximate to like bispecific, trispecific antibodies to approximate tumor and an effector cell. And so there's a lot of excitement in oncology. So I'm very jealous of oncologists because they're always working with something new. And it's been making a difference. There are 1.9 million cases of cancer every year. That's 5,000 cases. So you'll see it in the United States, you'll see it in Canada and in Kenya, Ethiopia, South Africa, wherever you are, you're going to see cancer cases. And at least in the United States, our 10-year survival has really improved. And this is the beauty of this exchange, is that we can learn about what's happened on the continent as well. And so I'm eager to learn about cancer in Africa. And you can see that on the left, there's a graph of survival, or this is death rates actually. It's gone down significantly for both males and females. And this is credit to the new lines of therapy that have been developed in the last 20 years. The fast track that the FDA has opened, and the European equivalent. And so they've really moved the needle in oncology. So attribution is always tricky. The victor writes the history books, right? And so there are multiple origin stories of immunotherapy, but it's generally attributed to a surgeon by the name of William Coley. So William Coley was a cancer surgeon. So back in the late 1800s, early 1900s, the only thing you could do for cancer is surgery. And so he would deal with mostly sarcoma cases, and he would perform amputations. And so anyway, he observed that that the patients who developed post-op fever, post-op infection, would actually have better cancer outcomes if they survived the infection. So he had this theory of that it was important to rev up the immune system to treat the cancer. So he intentionally inoculated patients with strains of erysipelas and other bacteria. So talk about like out of the box thinking. So many in the scientific community dismissed them as like quack medicine. Like, who's going to sign up with a briefcase? Would show up, hey, you have cancer. People would come see him, and he would open up his briefcase, pick, with vials of bacteria, and pick which one to inject you with. And so anyway, that was after he died or retired in the early 1900s. It fell out of favor. But almost 100 years later, his theories were vindicated with the arrival of checkpoint inhibitors, and made it to the cover of Science as the breakthrough of the year, and really of this generation. And James Allison and Tasuku Honjo were awarded the Nobel Prize in 2018 as a result of this theory that William Coley had so long ago. So let's talk about how they work. If I can advance the slide. Okay. So within the landscape of the cancer microenvironment, there are significant immune events that occur. And one of them is antigen presenting cells. Antigen presenting cells are all over your body, your skin. And anyway, they take bits of dying cancer cells and they present it to T cell. And T cell, gathers the troops, activates other immune cells, and tries to attack whatever wherever the antigen came from. And so this is part of our immune system. And unchecked, you can imagine the T cells would do damage to a lot of normal tissues. So there is a break on this response, and that is the CTLA4 receptor. And so that's one scenario. The second scenario is where cancer cells become quite clever, and there's another break on the immune system called PD-1. This is programmed death 1 with this ligand PD-L1 and 2, and so cancer cells, to evade the immune system, start expressing PD-L1, PD-L2, and turn off the T cell response, and so the cancer cell can continue to divide and worsen the patient's illness. And so what immune checkpoint inhibitors do is take the brakes off the immune system. So they inhibit CTLA4 so that T cells continue to stay active against the antigen and wherever those cells are, whichever cells are presenting that antigen. And in this instance, despite having this PD-L1 expressed, the ligand expressed, the T cell would remain active against the cancer cells. And so you can see the type of drugs, the IPI, the Pembros, and the various drugs that target these receptor ligand pairs, combinations. So ipilimumab, a CTLA4 inhibitor, was the first CPI developed and was first to go through the trials, and soon to follow was nivolumab. So they were doing trials for the first 10 years or through the early 2000s, and it was approved in 2011 for melanoma. So this is a sentinel year, and so it worked amazingly in melanoma. Patients, even with stage 4 disease, would have regression or cancer-free survival. I mean, this was basically a cure for a lot of cases of advanced melanoma. So logically, oncologists thought, well, maybe this would work in other cancers. And so you can see this explosion, all these red dots of new indications for checkpoint inhibitors. So now 30 to 40% of cancers are eligible for this therapy. In other words, you guys will see it. So even on the continent, I've talked to my colleagues, and there are places in parts of Africa where immunotherapy is used, and so we'd love to hear about your experiences as well. But you can learn from our experience. And so you can see at MD Anderson, the use of checkpoint inhibitors really take off as the indications have expanded. I mean, we're using immunotherapy for more and more cancers. And so this is something that we need to be aware of. And why do we need to be aware of it? Because of off-target adverse side effects. As nephrologists, we need to understand this. So the pattern of induced autoimmunity or immune-related adverse events is a little different with the PD-1, PD-L1, and CTLA-4 inhibitors. You can see, like, for example, more colitis or high-grade colitis and CTLA-4 versus patients with receiving PD-L1. And then I guess predictably the combination, there would be a higher rate of immune-related adverse events, about 60% with the combination therapy. So this sounds like it's more trouble than it's worth, but an immune-related adverse event is actually a predictor of response. And so a lot of these complications can be managed with some steroids, a brief period of steroids and supportive care. And if the injury or the goes away, then perhaps you can re-challenge them with the therapy. And so we'll talk more about that in the renal context. So let's move on to a second case of a 63-year-old man with a metastatic renal cell carcinoma treated with Nivo and cabozantinib. That's a tyrosine kinase inhibitor. And he developed AKI with creatinine of 4. He had some hypertension and some well-controlled diabetes, just on some ARB and thiazide, calcium channel blocker, nothing to write home about on his exam, with some bilateral, trace bilateral edema. So you can see his creatinine went from 0.9 to 4. And in the ER, he received some predictably 2 liters of IV fluids. And so that did improve his creatinine some, but it wasn't really changing after several days. His urinalysis showed that, was 1 white blood cell. Let's see, proteinuria was 0.1 gram per gram. Urine eosinophils are negative. Platelets were not exactly where he was thrombocytopenic, but no schistocytes or anything like that. Ultrasound. So for the trainees in the crowd, we always want to develop a differential diagnosis, just like in morning report. Is it pre-renal? Well, we check that box. Is it post-renal? We got an ultrasound. Is it intrinsic? Probably. Is it proteinuric, non-proteinuric? Is there associated thrombocytopenia? So on and so forth. This gives us a differential. Is it, in other words, is it related to the tyrosine kinase inhibitor? I would say likely, not. I might have a slide on that, but in any event, he was treated. Actually, I want to ask the audience here, and I think this may be a good idea for maybe Pooja to comment. Would you biopsy this patient at this stage? So he has AKI, got some supportive care, and it's not really improving. And the question is, well, there's a couple of ways to skin the cat. And so you can answer for yourselves. Would you biopsy or not? It really depends. So I would say several years ago, I think we would biopsy this automatically. I think these days we would maybe empirically treat, given ruling out other causes, the morning report exercise that we all do, we have to do with every single patient. And so I, would elect probably to empirically treat this patient unless something unforeseen is happening that doesn't fit the pattern. And so, but in fact, we did biopsy this patient, rip-roaring acute interstitial nephritis with eosinophils everywhere. And so this is classic CPI-induced AIN, or acute interstitial nephritis. And so this is how it would look. So AIN is the most common pathology seen in renal biopsies when CPI toxicity or renal nephrotoxicity is suspected. There are very few clues in the urine, and so one of my colleagues I confer with always says, Well, urine is a horrible negative predictor value, predicting, sort of test. And so as a poor negative predictive value. And so if you don't see sheets of, this is rip-roaring AIM, we've confirmed it with a biopsy, but there's one white blood cell. So that can't be a way of ruling out interstitial nephritis. And so same thing with urine eosinophils. So just be very careful interpreting the urine. Obviously, we want you to look at the urine, spin the urine. If you see white cell casts or sheets of cells, etc., then clumps and things like that, maybe that's a sort of positive predictive or adds explanatory power. But if it's not there, then you still can exclude interstitial nephritis. And so we'll talk more about PPIs and how that can raise the risk for acute interstitial nephritis in the setting of checkpoint inhibitors in a further slide. And so, there have been several surveys looking at the rates of CPI nephrotoxicity. We have a renal group here that just the CPI work group, and there's we have a couple representatives from our section on that, because CPI nephrotoxicities happens fairly often, especially in light of how many patients are being treated. So 2 to 5% is actually a big chunk of patients. And so you can see surveys by Cortazar, Sitapathy, and this current report, or the report that I have flashed here, is a report from 2020. And I think he had 600 in his cohort, and roughly 2% were developed CPI nephrotoxicity. And I think he observed less nephrotoxicity with PD-L1 compared to other checkpoint inhibitors. Okay, so this is a report by Gupta and his colleagues in 2021 looking at CPI nephrotoxicity and risk factors. And so what I want to point out here is that, look, it looks like the younger you are, the higher your odds for developing CPI nephrotoxicity, which kind of makes sense. If you're younger, robust immune system, you might have more immune-related events. But what I really want to point your eyes to is the PPI, that's proton pump inhibitor, used for reflux and some other things, sometimes used for style. Like half the time patients don't even need to be on a PPI, but they're on it. These are obviously important medicines to prevent Barrett's esophagus and esophageal cancer and reflux symptoms, but sometimes are just on a patient's med list. But yeah, this is an extremely high risk. And so I always advise my oncology colleagues to consider stopping or using alternative to PPIs when planning to treat patients with immunotherapy. And then if you've had a prior immune-related event, then the likelihood is that you will have another one. And so those are risk factors for CPI toxicity. So back to our case. So what do we do? What do we do next? So do we actually, let me advance the slide. This is what happened to the patient after a short course of prednisone. The creatinine improved to near baseline. And so the question is, well, do we re-challenge with ICI therapy? And so the first question I ask the oncologist as a consultant is the cancer cured? Oh, no. Okay. Is the cancer responsive to the IC therapy? Yes. Then go ahead and treat. And so it's very simple conversation with my oncology colleagues. And so we re-challenge, and sure enough, the patient redevelops AKI. Sometimes with prednisone, you can have side effects, diabetes, cataracts, and so many other things. So you don't want to overexpose patients to prednisone. And so we used infliximab. Also, prednisone dampens the response to the checkpoint inhibitors, which you don't want to do either. And so we have developed a algorithm to use infliximab here at MD Anderson and some other places. And so sure enough, the patient responded again, and the patient was able to continue the immunotherapy. So this is a report by Cortazar looking at cases of AKI treated with from CPI toxicity, treated with steroids and no steroids. And you can see, again, the numbers aren't, the sample size is not so robust where you can make heads or tails, but in general, it makes more sense to, I think, treat with steroids. And then patients who are re-challenged, there's a good chunk, about 23% in this sample, that redeveloped AKI. And again, you might want to consider treating with steroids or infliximab. And then on that thought, this is our very simple algorithm. You probably can't read the letters or the writing here, but this is basically our approach to CPI, nephrotoxicity. And the first thing you'll see is acute interstitial nephritis. And the first, you might want to just empirically treat, but sometimes, we'll get to the question of biopsy a little later, but let me just continue that certainly if there's no improvement in the creatinine, or if the creatinine again goes up again, you might want to consider infliximab. And then beyond that, it's really, the book is unwritten. There's a lot of green space, need for research, and again, why we need to share this with you, so you guys can do the research out there and be inspired to fill in the gaps in our practice, our approach to these cases. And so also checkpoint inhibitors can cause other weird things in the kidney, various glomerulonephritides that look like lupus, that look like FSGS, that look like IgA, polyimmune. I'll give you some examples in some later. And we end up treating the lesion. And so this is what the rest of the algorithm basically shows. So let's go to a third case that sort of exemplifies this, or is an example of this phenomenon. So this is of a 71-year-old white male, not Asian, white male, 71. He had some hypertensive kidney disease, but otherwise never had any hematuria, nothing like that. He developed a melanoma, and it was excised and received some therapy, but he redeveloped metastatic disease, and so he had a recurrence and treated with ipi and nivo. So after the third round of combination therapy, his routine lab showed that creatinine went from 1.4 to 2.2, and he developed anasarca. So he showed up to the ER of shorter breath, and after certain days in the certain number of days in the hospital, we ended up biopsying him, and this is his biopsy, and you can see a proliferative lesion. Proliferative. We don't see AIN. What we see is a proliferative glomerulonephritis that stains for IgA, which is quite odd in a 71-year-old white man, and for the first time. And so we attributed this to the CPI toxicity. And so this is his creatinine graph. Let me just orient you on the ordinate, is the proteinuria as well. And so you can see that the proteinuria was extremely high, 8 grams. He had 8 grams of proteinuria. We decided to treat him with steroids, and sure enough, the proteinuria improved. And then we stopped it, and he redeveloped proteinuria again up to 7 grams. And mind you, he's no longer on immunotherapy at this stage. So anyway, we retreat with prednisone for a longer period of time, over 3 months. And so anyway, he responded. And then as we tapered, he redeveloped a proteinuria. We gave him rituximab, and then followed by Actar, and that seemed to calm his disease down significantly. And I followed him for approximately 3 years after his last dose of immunotherapy, and he still required, if we stop these agents, that so completely out of his system. The immunotherapy is out of his system, yet his body, he has for the rest of his life IgA nephropathy, podocytopathic IgA nephropathy. So it's not even a typical case. It behaves more like minimal change in this instance. And so anyway, he required continued treatment. And so that's the very odd thing about checkpoint inhibitors and nephrotoxicity. And so we at MD Anderson have biopsied several cases of polyimmune. This is from Dr. Mamluk and Dr. Abudaya. All my colleagues have biopsied various lesions, including polyimmune glomerulonephritis. We've biopsied a membranous nephropathy. We biopsied vascular nephropathy. It's insane. So it's like a box of chocolate from that great movie. Forrest Gump, but it's quite interesting. So remember, about 80% of the time you'll see interstitial nephritis, but 20 or 10 to 20% is just potpourri, anything goes. And so how about CPI use in transplant? If you use it in transplant, patients tend to reject. And so this is always a Sophie's choice to decide whether to treat the cancer or end up on dialysis and lose the allograft. As far as risk factors, it's just the sample sizes are just too small to make heads or tails. Also, remember that CPI toxicity can also cause lesions in the pituitary gland, the adrenal glands, and so patients are at risk for hyponatremia. So again, as a nephrologist, you're on the front lines of this, recognizing this hypokalemia, distal RTA. I have a case here looking at the bicarbonate here. If you just, it's kind of small, but the patient has a normal gap acidosis with positive urinary anion gap, and the degree of acidosis is kind of out of proportion to the renal failure. And so this looks like an RTA treated with steroids, and it improved. And so we think it also causes an RTA. So we do have a hyponatremia clinic. I think it's a good idea for any cancer center or any group that's treating cancer because it's so common. We also have patients with platelets of 1. And so we are always on the lookout for non-invasive biomarker monitoring. And you can see our colleagues at the Harvard programs, Megan Seiss and others, looking at soluble IL-2 receptor as a potential marker for ICI toxicity. There's exciting work occurring even at MD Anderson, looking at tertiary lymphoid structures and the chemokines such as CXCL9 that might be a signal for CPI-induced nephrotoxicity. And Dr. Murakami and others, you can see that this type of research requires collaborative effort. And so that's why I included this author list, to show you that we have to work together in order to make progress in this complicated science. And so there are gene expression analyses using heat maps and things like that for biopsies, whereby we can detect ICI-induced nephritis, because it's very difficult to distinguish that from T-cell mediated rejection and some other problems that can occur in allografts. And so this has fueled an explosion of interest in onconephrology, which we're seeing here with this audience. And so, you know, before we were just characterizing disease, now we're doing prospective trials, and we want you to be part of that vanguard, and especially as you guys use more of these novel agents moving forward. We do have the American Society of Onconephrology that was established in 2022. We have a WhatsApp group. If you have cases, we're happy to comment on it. Of course, honoring any protected health information. We have a website and also a fellowship that has been established a number of places, including Mayo Clinic, MD Anderson, MSK. And so we also have symposia. We had 300 participants, including my friends from Kenya, from Kraken, who attended. I think we had 3 members who attended virtually. We want to make sure that there's no barrier to accessing this kind of information through webinars and online access. That all our symposia will be hybrid. So you can be part of the club. We want you to feel included. So even though there's American Society of Onconephrology, it is really, we want it to be international. We're an ISN affiliate. So the next Onconephrology Symposium is in 2024. It'll be this year, September 13 to 14. So make it to New York. And if you can't, just please be present virtually, and we'll make it engaging. This is our website. Again, we're an ISN affiliated society, just like AFRAN. And we have free membership for any trainee. So every trainee should be part of this, any nephrology trainee. And then certainly if you're from a low-income country, we follow the ISN model, whereby the fees are adjusted for the country that the individual's applying or from. And so we want to include everyone, and because we're going to tackle this problem more effectively together than in our own separate silos. So in summary, CPI related nephrotoxicity can manifest in diverse ways. We talked about the various glomerular lesions, the AINs, the extrarenal manifestations, the electrolyte disorders, the RTA. I mean, it's insane. So I hope you agree with me. That is the new great masquerader. And so you have a central role as a nephrologist, as educators. It's your responsibility to make sure your trainees understand this this potential complication in onconephrology and everything else that onconephrology. I mean, this was what in the last 10 years, and imagine what the next 10 years will bring. And so you want to be on the forefront and be involved with ASON and everything we're doing. And so we want you to be part of that development. And so with that, I'll answer any questions. Hopefully I didn't go over too much.
Not all.
Much time.
It's perfect timing, actually.
Okay.
Is Dr. O there to?
Dr. Odhiambo, I think he's fallen off, and I had invited Dr. Odhiambo on as an oncologist from Nairobi. Pooja, Prof. Biru, and I think Wesley and Ugochi can attest to this. I feel like we have a lot of learning to do. You were talking about the young nephrologists, but I think we have a lot of learning to do.
Okay. Yeah.
We have two questions in the chat. Dr. Swinford has raised her hand. So Dr. Swinford, if you want to unmute yourself and ask your question, please go ahead.
She might not be able to.
Or you
I
can
think
even
I'm
type
Yeah,
Am I
you're
unmuted?
Yeah, we can
Yeah,
hear you, Dr.
yeah.
Swinford.
Oh, great talk. Thank you so much for putting this as your main topic as the first talk. So recently, as part of an investigational research board, there was a study in pediatrics using the checkpoint inhibitors. And I raised the question of the kidney issue. And, you know, the literature just doesn't, it is like a little paragraph when you look for side effects of checkpoint inhibitors. And the group really resisted any monitoring of kidney function. And this, of course, was in children. So I wonder how to make this more widespread. I know you said 1 to 5%, but
I would
what do you
say
think?
I would say that you know, it's an immune event, and so so one of the questions I got at another conference is, well, is it a cumulative toxicity? No, you can do it first dose. You know, one of the I glossed over one of the papers. I think it was by Sitapathy. He looked at when the toxicity would occur, and it ranged from you know, several weeks, like 3 weeks, up to 67 weeks. And so it could be your third dose, it could be your 15th dose. And so, you know, I think of it more like, you know, if you're allergic, you had anaphylaxis, anaphylactic reaction to peanut butter. Well, you know, a little bit of peanut butter, a lot of peanut butter. It doesn't matter. It's the immune response. And so I think it can happen in any individual. And so certainly children qualify. If you have an immune system, I think you're more of an expert than I am, but usually after like 6 months of age, I think you have a decent immune system. So I would imagine that it's something that you have to monitor. Like it's a matter of you know, of managing the patient. Not even, it wouldn't be above and beyond. I think you would need to monitor renal function very closely while patients are on checkpoint inhibitors. That's why we get so many referrals, because the oncologists all know to monitor for immune-related adverse events.
Yeah, but maybe our aspect of it is not in their journals, you know, and they don't read the nephrology journals. That's kind of what I was finding when I, you know, went back to look. Some papers don't even mention kidney issues.
Right. And I showed that one paper where the younger you are, the more robust or frequent the IRAEs are. And so
yeah,
you know, so I would imagine your crowd would be high risk for developing.
Well, we don't know because they're just being used now. For instance,
I
this
see.
group was going to inject it into the fourth ventricle for glioblastoma and other CNS tumors.
I see. Yeah. So I would stay vigilant.
Can I just add on and just say, Dr. Swinford, that while you're talking about pediatrics, I know pediatrics is so much underserved in nephrology in general. And now I'm trying to think about onconephrology. But in the same way, why I talked to Dr. Odhiambo about it is we had a patient on ibrutinib the other day, and the patient comes in proteinuric, and I was like, is this right? Is this normal with this? And he has an AKI and his creatinine's going off. And we were trying to look into the literature, and just there's some literature, and you just don't really know. Patients have not been followed up for long enough. We have no data in African patients, of course. So what to expect and what to think about, and that's where your question comes in, Professor Biru, of should we biopsy? Because we're not really sure what's happening here. Is it just a secondary GN because of a malignancy? Is it? So it really is just an eye-opening session. That's just my addition to this. Yeah.
Yeah, plenty of
Absolutely.
opportunities. I would say especially as you're adopting these agents to biopsy as long as it's safe, more than not. And so you get a better handle on the epidemiology. Yeah, and the same thing we did. Yeah.
Thank you. There are two more questions in the chat. So one question says, thank you for the excellent opportunity to learn. How do you manage a patient with AKI in the background of treatment, naive uterine malignancy?
AKI in naive.
Treatment naive uterine malignancy.
Okay. So, I mean, yeah, any woman with AKI with a abdominal tumor, it's you want to put a probe on her ASAP, a hydronephrosis until proven otherwise, and then go through the same differential of, is it pre-renal, post, is it intrinsic? If it is intrinsic, what other medicines the patient's on, so on and so forth. But treatment naive, it would be what's out there in the community. So whatever your other patients with AKI are at risk for, this patient will be at risk for, in other words.
Awesome. So two more comments and questions. Thank you for the beautiful presentation. Many times we are asked by the oncologist to give advice on the use of chemotherapeutic agents. What would be your advice to use checkpoint inhibitors, avoid renally adjust doses?
Oh, so I don't think there's an adjustment for these agents. They're not really cleared by the kidneys. Someone can double check me on that, but it's more of giving it a break if there's some off-target toxicity, and so as far as deciding what agents to use, honestly, I would leave it up to the oncologist, because you want to focus. You're not going to have a patient if the cancer is not treated, in other words. So, and so I didn't spend too much time talking about like what to do in a transplant case, but if half these cases reject, you have to have a real talk with your patient. It's a real Sophie's choice. It's like you have to choose between one child versus the other. So I've had some patients say, look, I never want to see dialysis again. I'd rather, die than and you have to respect that. And so on the flip side, please treat my cancer, and whatever happens to the kidney is whatever happens to the kidneys. So that's the level of interaction I have, whether to treat or not to treat. But in terms of choosing the recipe for the cancer, I'm not qualified as a nephrologist. It would have to be the thoughtful oncologist to confer with me if they have questions about one drug or another. I would imagine, let's say, cisplatin or some other agent, if the GFR can take it. Those are the kind of questions that we can answer. But what to actually prescribe, we're not invested in that literature. So we work together collaboratively.
And I think you put it so beautifully, and even in my practice, the way I see it is like the nephrologist's job is oftentimes a simpler job of just discussing with the oncologist and the patient and kind of having that discussion, whereas the heavy burden lies on the oncologist in terms of choosing the treatment options and things like that. And with the expansion of use of these medications, I think even patients with one kidney, half a kidney, and or CKD are being offered these medications. So on one hand, it is really exciting that some of these patients would not have had therapy otherwise, So kind of finding that balance between what we can offer them and supporting through them, I think that's been like a very rewarding task for me personally to to connect with the oncologists and sort of have that discussion. So I think that's the nice part of my job too. And we have one more person who has raised their hands. Are you able, Dr. Abdullah, are you able to unmute yourself? We have maybe one last question. All right. While we figure that out, somebody has written something really beautiful about the whole symposium, and I'll just paraphrase. And they're very happy to have this symposium, and they're so excited to be a part of this. So yeah, and you can always reach out to us, and we can help in any way we can.
So
all
kudos
right.
to Dr. Soki, Pooja, and everyone that put this together. So thank you for letting me be part of it.
Awesome. Thank you for the great talk. That was really, really amazing.
It's really been, I think, eye-opening as to the scope, and has really challenged us in terms of what we need to do and what we are able to do. So thank you, Prof, for that.
Right.
Pooja, shall we move on to the second talk? I think we're trying to keep time, but I think we can go on here for quite a while.
Yeah, absolutely. And then
Thank
we will still have a few minutes at the end. So
yeah. So I think our second speaker is Dr. Wesley Tulican. And Wesley is the head of nephrology at Dr. George Mukai Academic Hospital. Wesley, you promised to tell us how to pronounce this correctly. You'll just correct us. And he's a senior lecturer at Sefako Magato Health Sciences University. I know I've massacred that. But I met Wesley last year when we were at the World Congress in Thailand, and he's an accomplished academic with a diverse background in nephrology and genetics and infectious disease and immunology. He's amazing. And he's really driven by the goal of bridging the divide between clinical care and medical research. So using this expertise to improve patient outcomes and providing quality education. And it's just a privilege to have you on with us, Wesley. And I'm going to hand over to you, correct our pronunciation, and share your slides.
Thanks, Khalida and Prof. Wakana. Sorry, I'm not sure if I'm pronouncing your surname correctly. Thank you for this opportunity. This is really great, and this is a really great platform. Prof, I'm glad you brought up the concept of the Great Masquerader, because I'm going to be presenting on a monoclonal gammopathy of renal significance, and it is also a quite a masquerader. And the more I dug into it, the more I was amazed, and also I was just reminded of autoimmune diseases like lupus, where it depends on the different types of antibodies. And it was a bit of a rabbit hole, but a fun one nonetheless. I'm going to share my slides quickly. Here we go. So I'm Dr. Wesley van Tulican. I'm the head of renal at Dr. George Mukai Academic Hospital and the Sefako Magato Medical University in Gauteng, Pretoria. Lots of difficult names there, but my apologies. And I'm going to be talking on monoclonal gammopathy of renal significance. Just a bit of background. Dr. George Mukai Academic Hospital is the second largest hospital in South Africa with 1,652 beds officially. It's actually in a rural setting. If you look at the bottom image there, that I took that picture on Wednesday as I walked out the renal unit, and there were a couple of vervet monkeys playing on a jungle gym just outside the renal unit. But this is not going to stay like this. The area is undergoing rapid urbanization, and that's going to affect our healthcare as we go along, and the population is expanding quite rapidly as well. I'm going to be talking on monoclonal gammopathies of renal significance. I'm going to start out with an introduction, a definition. Then I'm going to discuss a case that I had back in 2019. And I still have a couple of questions about it, but to me, it's very, very interesting. We're going to talk about the pathogenesis, diagnostic criteria, standard treatment, and different treatment algorithms for monoclonal gammopathy of renal significance. And Joss, let's get started. Okay, so monoclonal gammopathies. We've known about monoclonal gammopathies of unknown significance, so MGUS. There we have an abnormal B cell clone or plasma cells that are usually pre-malignant, but they produce an abnormal antibody, and it can be any antibody, but it's usually IgG. And it can be the heavy chain, the light chain, or both. And usually there's no discernible clinical manifestation, and there's no overt malignancy. There are specific numbers that I will get into just now. But what I've done here is I've put on a basic serum protein electrophoresis, showing you the different types of proteins that we normally look at. And I mean, you've got your albumin, your alpha 1, alpha 2, beta 1 and 2, and then your gamma globulin area here. And if you look at the image on the right, you've got a normal serum protein electrophoresis with, this is a polyclonal gamma globulin band. But if you have a look over here, you can see that it's quite darker, and this is what they call the M spike. And that's usually due to a single gamma globulin molecule that is being overexpressed by a single clone of cells. And they use the term clone, just like most cancers are clones of themselves. This is usually a pre-malignant clone, but you can also think of it as a clonal expansion of a B cell population in response to something that has just not been turned off. It's another way of looking at it. So it's clonal expansion, but not malignant yet. Monoclonal gammopathy of unknown significance is uncommon. Only 3.2% of people over the age of 50, but it increases with age, and it almost doubles by the time you are 70 years. Usually there's a fear of progression to multiple myeloma, but that only happens at about 1% per year. However, there is a 20% lifetime risk. So if you develop a monoclonal gammopathy of unknown significance, your risk of having multiple myeloma in your lifetime is 20%. There is the monoclonal gammopathy of renal significance. It only affects 2 to 10% of the monoclonal gammopathy of unknown significance. So it's a very small percentage of the population at any one time. So if we assume the worst, the monoclonal gammopathy of renal significance will affect 0.3 to 0.5% of the population at any one time. So it's quite rare. But when it's there, it's important to recognize it, and I'll touch on that just now. Coming to this this cartoon here, here's the diagnostic criteria for MGUS. You have your M protein that's less than 3 grams. nothing in the urine, and you have less than 10% plasma cells in your bone marrow. And there are no myeloma defining events or amyloidosis. As I said, progression risk is 1% per year. A smoldering multiple myeloma, you have 3 grams or more of your M protein, a lot more urinary protein, but this is the M protein, not to be confused with albumin protein. I mean, albuminuria or proteinuria. This is specific when you're looking for Bence-Jones or you do a urine protein electrophoresis. And here the risk of active multiple myeloma is 10%. So your risk is much larger. And somewhere between your smoldering multiple myeloma and the newly diagnosed multiple myeloma is when you get your typical CRAB symptoms. Obviously, it happens, the more advanced the multiple myeloma is, the more overt the CRAB symptoms are. But you can start presenting with CRAB symptoms in the smoldering phase. But now your monoclonal gammopathy of renal significance arises over here in your monoclonal gammopathy of unknown significance. So it's a subset of the unknown significance, where basically the antibody starts to have an in-organ effect, and that's mainly obviously in the kidney. And what's fascinating about this is it depends on the type of antibody, its characteristics, physiochemical characteristics, where it gets deposited in the kidney, and it literally can be anywhere in the kidney. I'll show you a couple of slides just now of how diverse this disease actually is. Just coming back a step, the monoclonal gammopathy of unknown significance, it's mostly IgG molecules, some IgM, there is some cases of IgA. The immunoglobulin delta is very rare, and that's usually associated with multiple myeloma. But what I find interesting is that you can actually have biclonal gammopathy. So you have 2 clones of antibodies that are different from it might be from the same cell producing 2 different antibodies, maybe a light chain and heavy chain, or 2 different clones. It's entirely possible. And if you have take that one step, you can potentially have an oligoclonal. I'm not aware of it being documented, but I can definitely envisage that it's possible. There will obviously be a predominant clone, but that's more it's academic hypothesis more than anything else. So, yeah, but the concept is interesting. Also, you have your light chain that happens in up to 20%. And it's usually your kappa light chains, not so much your lambdas. So the real definition of monoclonal gammopathy of renal significance is that it's a clone of non-malignant or pre-malignant B cells or plasma cells that secretes usually a monoclonal immunoglobulin, which leads to kidney damage. You do get other monoclonal gammopathies that target other organ systems, but we're going to be focusing on the ones of renal significance. In addition to this, you need to have your serum monoclonal immunoglobulin of less than 30 grams per liter, and you need to have less than 10% of monoclonal bone plasma cells in your bone marrow. And this was proposed by Leng et al. In 2012, and then he wrote quite an article in 2017 and updated it. And I'll show you some images from that. So the points in 2012 that Leng and colleagues mentioned, I mean, these are going to sound quite basic, but it brings out a concept that is so important for when it comes to the renal disease. And it's overlooked a lot of the time when it comes to treatment. And this, I think, is what Leng and colleagues were trying to get across, is that because monoclonal gammopathy of renal significance is considered a pre-malignant and not a malignant, that definition that's in our head makes us not treat the patients as aggressively, but it allows for the progression of renal disease. And these patients often end up on dialysis. And I personally call dialysis life-saving torture, because that's really what it is. To sit on a machine for 4 hours, 3 times a week is not fun. But that is how that's the point here is that Leng et al. They pointed out, quite rightfully so, but in a basic way, for monoclonal gammopathy of renal significance is you need to have kidney impairment caused by monoclonal proteins, and that is distinct from the renal disease that comes from that is generated by multiple myeloma, so your calcium-induced nephrotoxins, your CAS nephropathies, and so on. The monoclonal gammopathy of renal significance is separate from that. Monoclonal gammopathy of unknown significance, there is very little progression, 1% per year, or 99% of people don't progress if you flip the numbers around. Whereas monoclonal gammopathy of renal significance, at 5 years, almost 70% of people will be CKD5, almost needing dialysis, and that's not insignificant. So this underscores that the seriousness of the disease and the need to treat. And that brings to the next point there, pointing out that often needs aggressive treatment. And when I show you what the treatment is, you'll see why it's considered aggressive. But if you're going to avoid somebody being on dialysis, it's quite necessary. And then basically they made the point that monoclonal gammopathy of renal significance must be distinct from MGUS, simply because of the difference in the progression rates. And they highlight the problem of withholding necessary treatment. And it's a subconscious thing. None of us want to withhold treatment from our patients, but we also don't want the unwanted side effects. So that's, we tend to, if it's non-malignant disease, subconsciously, you won't be as aggressive. But, we need to understand the disease progression here and the seriousness of this disease. So, as I alluded to, and Prof mentioned a great masquerader, I mean, monoclonal gammopathy of renal significance obviously isn't as much of a masquerader as syphilis or lupus, but there are a lot of diseases. And basically, if you can imagine a renal disease or renal damage pattern, monoclonal gammopathy of renal significance can cause it. And there are lots of caveats to this. And the case that I'm going to show you, one of those caveats was actually, I think, missed. Well, it didn't change the diagnosis, but I think it was missed. But I'll come through to that. But basically, you have you have this abnormal immunoglobulin, and when you do the kidney biopsy, you either have deposits or no deposits, and then those deposits can be organized or unorganized. And the organized are the ones that we more often know about, like amyloidosis. That depends on the chain that is deposited, light chain, heavy chain, or both. And the different fibrils, microtubule deposition, and then the one that I kind of like, crystal deposits. So the light chains get excreted or filtered out via the glomerulus, reabsorbed in the proximal tubule, and where they crystallize, and that causes proximal tubule dysfunction, causing a Fanconi type syndrome. And what they actually advocate for is, if you have someone who has a monoclonal gammopathy of unknown significance, and you can prove a Fanconi syndrome, you actually don't have to biopsy the patient, which I think I would still biopsy personally, but you've proven that there is monoclonal gammopathy of renal significance. As long as you've ruled out that they're not on any drugs, like in our case, tenofovir is very common in South Africa. But yeah. I'll put that in just to highlight the immunoglobulin and the light chain and the heavy chain, or both. So going on to our case vignette, 2019, there was a 71-year-old male that we treated. He was hypertensive, and he was on Lazar and Bicycor, which are angiotensin receptor blocker and a beta blocker. He had a baseline chronic kidney disease stage 4 with a creatinine of 154 micromoles. I didn't convert that to the deciliters, but I think it'll be just over 1, if 1.2, I think. I'm not sure. But the GFR was 39. He did have a smoking history. He presented with a nephrotic range proteinuria and massive, it was 14 grams. He also had hematuria, but there were no casts or abnormal cells. We unfortunately often don't see casts or abnormal cells in our setting. I'm not sure why. I think maybe we leave the urine for too long. I'm not sure. But his GFR had dropped from 39 to it ranged between 10 and 12. Hepatitis, BC, syphilis, HIV, and his PSA were all normal. He had a positive anti-nuclear antibody, but the rest were negative. His C3 was very low. Low limit of normal in our lab is 0.9. He had a mildly elevated CRP, but a very high ESR. This was his creatinine. So if you look on the or the first 2 lines at the bottom, there are actually the normal range of creatinine in our lab. Then above that is his baseline GFR. And then there was a test in 2018, and then nothing until he was presented in October 2019, when there was a massive spike in the in his creatinine, going up all the way up to about 700. So that's where he presented. He had a kidney biopsy and a bone marrow biopsy done there. So on the histology, his bone marrow was essentially normal. There were no evidence of lymphoproliferative disorders, and the plasma cells that were identified were polyclonal. The renal biopsy, on the other hand, it was a good quality renal biopsy, 22 glomeruli, only 1 sclerotic, which is surprising considering his baseline creatinine. There were 19 that had increased endocapillary cellularity with lobular accentuation. There was quite marked interstitial nephritis, and only 10% fibrosis and atrophy, and moderate arteriosclerosis. So this was a more proliferative type of picture. Then on immunofluorescence, a little bit of IgM in the capillary loops and mesangium. IgA, G, kappa and lambda, and C1q were all negative. but there was quite marked C3 immunoperoxidase staining. And I'm not certain as to why they did immunofluorescence for everything else, but not C3. But I mean, and they used immunoperoxidase, which is an older technology, but it's there. It was very, very marked. Then on electron microscopy, there were large dense mesangial deposits with subepithelial deposits, intramembranous deposits, and there was quite a large foot process effacement. And this is more or less in keeping with the clinical presentation, with lots of protein and a bit of hematuria. So we treated him unconventionally. So he received plasma exchange, solumedrol and rituximab, and then was maintained on mycophenolic acid for about 3 to 4 years. And I will come back to this at a later stage. The protein electrophoresis was essentially normal, except that they put a disclaimer in saying that they couldn't rule out a co-migrating monoclonal gammopathy. And they also noted that the beta-2 globulin fraction, which is your complement, was increased, which, considering what is happening in the amount of C3 that was deposited, it's not surprising. The kappa and lambda were both raised, but in normal ratios, and for the GFR, it was appropriate. So there's no abnormalities there. So coming back to this here, we have two possibilities. So it's assuming that this is we're making a big jump here because we couldn't prove a monoclonal band, but we could either have a proliferative glomerulonephritis with monoclonal immunodeposition, or a C3 glomerulopathy with monoclonal band. But I'll come back to this as to why I'm thinking about this. Coming back to Lang et al. In his 2017 classification, he had this very complex diagram or cartoon showing you how diverse the disease profile is of monoclonal gammopathy of renal significance. It can affect the afferent arterioles, and you can either get immune complex deposition of the myocytes, you can get an amyloid fibril deposition here, you can get cryoglobulinemia, you can get a crystal nephropathy in the blood vessels here. You can get a glomerulonephritis, and it ranges from deposition, like mesangial deposition, like an amyloid here, and then you get this is your proliferative lesions with immunoglobulin depositions, and then you get your immunotactoid glomerulonephritis. Then on top of that, you can also get a proximal tubule lesion, and talking about the crystals that get absorbed in the proximal tubule by the proximal tubule cells, the crystals deposit in there, and you get a Fanconi type syndrome. So it is literally any renal disease that you can think of, MGRS can actually mimic it. And then they go on to show us different images of it, but it's exactly the same as that other flowchart that I showed you. All they've done is they've just added some H&E stains with immunofluorescence. And then I just wanted to point out that there can be also thrombotic microangiopathy as well, without immune complex deposition. So in summary, monoclonal gammopathy of renal significance, and I've put in brackets here, also applies to monoclonal gammopathy of clinical significance, so that you can have other organ systems affected, is due to immunoglobulins, and it can be any of the immunoglobulins with variable epitopes, variable sites of depositions, and they can lead to variable renal presentations. But you need to recognize and treat them because of the high risk of end-stage renal disease. And the idea is to try and avoid dialysis at all costs. So what type of disease spectrum do we see? I mean, I've thrown a lot of information out there, and what type of patient are we going to see? So there's a meta-analysis by Du et al. It was quite recent. Now I want to say that it was in the last 2 years. I can't remember exactly, but they screened something like only 2,000 studies, not that many, excluded most of them, and they could only do meta-analysis on 6. So it's not great, and the sample size is quite small as well. And first of all, what they saw is that the majority of the disease was amyloid. Then there's monoclonal immune deposit disease, cryoglobulinemias, proliferative glomerulonephritis with immune complex, and then the rest are quite rare. What they found was that the predictors were older age, which kind of makes sense. Like MGUS, the older you are, the higher the prevalence. So if we take that and extrapolate it, it'll be the same for monoclonal gammopathy of renal significance. Higher urinary protein, higher, and they also go to say above 1.5 grams is predictive. Higher lambda chain values, then the kappa lambda ratio, if that's abnormal, and if there's an abnormal bone marrow, if a bone marrow biopsy was done, or if that bone marrow biopsy was abnormal, that predicts MGRS, all of which I think would be self-evident as well. Non-predictors in the study were sex, creatinine, GFR, hemoglobin, C3, C4, presence of hematuria, and kappa values. There was one study that I read that they think people of African American origin also increased risk, almost double, and also people who are co-infected with HIV. But that wasn't reported on in the study. To establish the diagnosis, so you should always, if you have somebody who you've got a MGUS and you suspect MGRS, you should always do a kidney biopsy, except where you've proven a light chain amyloid diagnosed somewhere else, or a Fanconi syndrome in MGUS. I think like the first one I would definitely agree with. Like if you've proven AL amyloid, then it's most likely renal amyloid, and I'll try avoid a biopsy in the patient and treat for that. But if there's a Fanconi syndrome, it's a bit too variable. I think I would rather do a biopsy in that patient, but there is some literature to say that you don't have to, you can treat first. I'm bit hesitant on that, but that is what the literature says. Now, coming back to my case that I presented, so the C3 glomerulonephritis, you may not be able to see monoclonal deposits. And they actually suggest that if you suspect a MGRS and you get a C3 glomerulonephritis or a pattern that is suggestive of that, then you should actually do, you should digest the slide to unmask the monoclonal gamma immunoglobulins. And in our case, that wasn't done. So we might have actually missed the immunoglobulins. And then the proliferative glomerulonephritis, they note that the SPEP is negative in 80 to 90% of patients. And that's exactly what we saw in our patient. He had lots of SPEPs. I didn't actually count, but there were over 10, I think 3 when we first did the when you first presented, but over 10 going forward. Then if I can just point you to here, if you do a kidney biopsy, 40% will be expected to have a MGRS pattern, and the most common is AL amyloidosis. And in the 60% that there's not a monoclonal gammopathy of renal significance, the most common is arterial sclerosis. And if you remember back to our patient, he had mild to moderate arteriosclerosis already. This is a nice workup for the patient, and it advises you when to do a biopsy and when to be more aggressive. But basically, you'll have a clinical suspicion. You'll do your basic serologies, and I've just put in there to include urine analysis and serologies just to screen for Fanconi syndrome. Always do monoclonal protein testing. And that's not only the serum SPEP and the serum-free light chains, but also urine SPEP. It sometimes picks it up in the urine. Very rarely urine only, but it's possible. Bone marrow aspirate and biopsy is quite important. Kidney biopsy, I think, is very important here. And then they suggest doing a CT chest, abdomen, pelvis. This is to look for plasmacytomas, also the PET test. The idea is that occasionally you can have a plasmacytoma that is not, you don't see it in your bone marrow, and you can find it using radiology. Yeah. So the treatment, you have a couple of goals. One is to preserve renal function, and then others to prevent extrarenal manifestations of disease. It's based on the pattern of injury and the monoclonal immunoglobulin type. They go to specific pains to say that the treatment doesn't prevent or reverse any of the deposits. It targets the clone of the cell, so it doesn't target the antibody itself. And it also depends, your choice of treatment depends on the kidney function and the level of fibrosis on the biopsy. There's no point in doing subjecting a patient to aggressive immunosuppression when their kidney is 95% sclerotic. But there's a caveat to that, and I'll come to that now. So the core drugs in the treatment are proteasome inhibitors, usually bortezomib, your monoclonal antibodies like rituximab, your alkylating agents like cyclophosphamide, immunomodulatory drugs, thalidomide is most commonly known, and your glucocorticoids, mostly dexamethasone. And broadly speaking, it depends on if there's if you can detect a plasma cell or a B cell. So you're going to be using bortezomib if there's a plasma cell, and rituximab if it's a B cell, and together with cyclophosphamide and steroids. And similarly, the pattern repeats itself. So if you look here, plasma cell, VCD is bortezomib, cyclophosphamide and dexamethasone. RCD is rituximab, cyclophosphamide and dexamethasone. If there's an IgM molecule, you're going to use a rituximab-based regimen. If it's non-IgM, you're going to use bortezomib. And this pattern kind of repeats itself, except when you're in the conservative treatment. And the conservative treatment is when you can't detect a monoclonal antibody. You have to be careful, and you have to have shared decision making with the patient, and you need to share the risks and the benefits with the patient, and then try and make a decision together to go forward. As I mentioned earlier, when not to treat, obviously when the patient declines treatment, and when there's end-stage renal disease with renal fibrosis, there's no hope of renal recovery, then there's no point. However, you can treat an end-stage renal disease when there's non-renal target organ damage. So say there's amyloid and it's affecting the heart or somewhere else. And also, if you are planning a kidney transplant, remember you're treating the B cell clone and not the kidney directly. So even if you've got end-stage renal disease and you're wanting to do a kidney transplant, you should treat the patient, because there's a very high recurrence rate of 80% post-transplant. Monitoring, they suggest that you do it quarterly, and you monitor your serum creatinine, your urine protein or albumin excretion. You can, depending on the type of monoclonal antibody, you can do a SPEP or serum-free light chains just for monitoring of the disease. If there's Fanconi syndrome, you obviously want to monitor that as well. You have to tailor it to the patient. So coming back to our patient, I've presented the treatment of monoclonal gammopathy of renal significance. And while there is a steroid and rituximab, plasma exchange is not there. So, and they don't mention mycophenolic acid mofetil at all. So why was this chosen? So what actually happened was this patient came in and he was presenting as a patient with a rapidly progressive glomerulonephritis. Initially he was pulsed with solumedrol, and the patient still progressed. So we opted to give plasma exchange, and then he had a very good response, and then consolidation was with rituximab. And most of this is because of diagnostic delay. A lot of biopsy turnaround time issues. There was a lot of confusion as to what was happening with the patient. It wasn't clear exactly what the diagnosis was. So we opted to be a bit more aggressive here. But then I want to highlight that there was no M protein ever identified. And we also didn't do the protease digestion of the renal biopsy. So the diagnosis wasn't actually really confirmed. Although if you weigh up all the options, it's most probably a monoclonal gammopathy of renal significance, probably the proliferative one with monoclonal deposits. Yeah, but there are questions. Also, that anti-nuclear antibody, could this, what role does that play? But the biopsy, there was no, it was only a little bit of IgM, no IgG, IgA, no full house. So not your typical lupus type of biopsy. So and his age is also makes lupus quite unlikely. So yeah, we're not sure. But wait, there's more. If you have a look towards the end of last year, he had a relapse. Creatinine didn't go quite as high, but it did go up. The protein electrophoresis again was normal. Bone marrow again was normal. There was no clonal expansion of plasma cells, nothing untowards there. The kidney biopsy, it wasn't as good as the previous one, but there were 10 glomeruli with severe arteriosclerosis. There was mild tubulopathy and no immunoglobulins were seen, but there was C3 and C4D, and the electron microscope showed no deposits. He was given a solumedrol pulse only, and he responded quite nicely. And questions here is, could there have been a acquired C3 nephritic factor, same with the factor H inhibitor? Was it biclonal disease with undetectable or very low monoclonal antibody? Was it just the solumedrol, and was the plasma exchange really necessary? I would probably argue that it wasn't necessary, but we didn't know at the time. Some references, and thank you. Are there any questions?
Wesley, thank you so much. You have made me reassess a number of my patients, and I think we're having rapid fire conversations on the side with everybody being like, oh my God, let's rethink Fanconis and let's rethink what our patients actually look like. What do you think, Pooja? How do you manage such patients? And I think, Wesley, at some point you said it might seem a little bit basic, and it really isn't, because I've asked Pooja, and I'll address this also to Andrew, because many times we come across these patients and they have nephrotic proteinuria, they're diabetic, or they have something else in the background, and their age, and you come across this monoclonal gammopathy, but it's not, there's no impetus on the oncologist side or the hematologist side. It's not treatable. It's not worth treating, but your creatinine is just going off, and it's like convincing them to treat it is a problem. What do you think? What have you find, Wesley, Pooja, and then Andrew can tell us a little bit from his perspective.
Yeah, so, personally, it's such a big challenge. And then a part of my population even has HIV. And when you throw in the HIV in the picture, the gammopathy from HIV plus the monoclonal gammopathy and the underlying kidney disease becomes incredibly hard. I personally find when there is either like one of the slides Wesley showed, that if there is a presence of hematuria, worsening kidney function, or something that cannot explain the whole picture, I think a biopsy, if you cannot biopsy any other organ, because I know some places, if you're thinking of amyloid, getting a fat pad biopsy is a good yield, but that may not be true at all places. So in that setting, I've become a lot more vigilant, because I think you can treat these patients with such good agents now. And then even if you look at in terms of what happens of them eventually, like progression or as they get better and as they get treated, their ability to be on like a transplant list or things like that. Also, patients are more aware now, at least in the Western world, about transplant and CKD. So in that setting, I would really be very displeased with myself if a patient were to go to transplant without having this basic workup, or even having a biopsy to understand. Sure, it might just show diabetes, but then at least we're ruling out something super important. So I also think that the collaboration with the hem-onc doctor helps so much. Like, having a discussion with them. Like literally yesterday, I saw a patient who has an IgA gammopathy, but has A1C of 17. and has a kidney function that is deteriorating rather rapidly. And the whole question was, the bone marrow is okay, he's had a skeletal survey that's negative, but then he does have this small IgA, and now he has some amount of proteinuria, and then what do we do about this? So I think a joint decision making approach with the oncologist definitely helps, and at least getting a bone marrow biopsy it's quite easy for us to collaborate with. So that helps me somewhat. It's not again, it's not would I like to biopsy this patient? Probably, now that his kidney function is particularly worse. But then how do you explain that A1C of 17? And I always feel like, hope we had an organ like liver, right? They biopsy the liver and the GI tract so many times and they're still okay, but we still have to go through the notions about the kidney biopsy. So that's my experience. But I agree with Wesley and you that we really do have to rethink about these patients now, because we have options, survivorship is better, and we have it's just a service to our patients to be more vigilant, I think.
And I really loved what Wesley said when he was like, life-saving torture. That's what dialysis is. And it's so important in terms of quality of life, but also in terms of mortality, to try and get patients to avoid dialysis. And that's part of what we do. What do you think, Wesley? What has your experience been with the hematology?
Yeah, so you've just actually brought up another very valid point. The mortality on say hemodialysis is not insignificant. It's something like 20% per year.
Sorry.
If you can avoid dialysis in your patient, with a bit of cyclophosphamide is not a walk in the park, but it's better than dialysis, that's for sure. So a bit of cyclophosphamide, dexamethasone, and rituximab, your quality of life is much better. And like Pooja was saying, there are so many diagnostic challenges with HIV is going to be a real one, because that's also a mimicker. And you can get a monoclonal band in HIV that can go away with ARVs. Now, you've got, often you're going to have a HIV positive patient who's going to have a Fanconi syndrome before you give tenofovir, who's going to have a monoclonal band. He's going to have lots of proteinuria. And do you biopsy this person, or do you just put them on ARVs and hope? And you can't predict. So this is where working as part of a team, I think, is so important. In our setting, like an infectious diseases person will be vital here. And onconephrology or oncologist will be absolutely vital. And considering in sub-Saharan Africa that we have such a high rate of HIV and other infectious agents, our infectious diseases colleagues are quite rare. So it's hard to find someone that you can chat to and or has the time, because they are very, very busy. But what I really liked with this topic is how diverse everything is, and it's because of how diverse our immune system is, and the different pictures that it can come up with. When I say pictures, are under the microscope, and the different disease presentations, and it's from an academic point of view, it's absolutely fascinating. And the fact that you can reverse most of this with relatively simple treatment is very heartening. And we tend to think in this patient, he was 71 years old. Why expose him to such hectic medication, when on the other hand, oncologists look at this and say, oh, you're using like baby doses of cytotoxic agents. We need to maybe be more aggressive in this field. But maybe other people have some insights there.
Yeah, no, I completely agree. And I think the spectrum of cancer now is more or at least in the Western world, what is happening is that cancer is becoming more a chronic disease more than an acute, devastating injury. Not taking anything away from how scary it is, but with newer therapeutic options and all these relatively safer bortezomib or rituximab and things like that, I think the approach is, it's not just a 71-year-old, but if it's like a 71-year-old who you can prevent from getting on dialysis, then in that setting, I think it's just the least you could do for them is to see, give them the best
It's
possible.
clearly the right thing to do.
I mean,
Yeah.
I recently had a patient, actually, Wesley, not recently, maybe last year, and this patient had a POEM syndrome, and trying to put this together and say, look, we have to treat this monoclonal gammopathy. That was another thing. I don't know if Andrew's on, and he can comment the challenges that we have maybe diagnostically, but in the meantime, there's just a couple of questions which we can answer really quickly because we're done with this and we can go on forever. Go on, Andrew, tell us what you think. We're really throwing you under the bus.
Thank you. I'm dialing in from the mall actually.
I know you're busy teaching.
So I'm just trying to multitask. I really enjoyed the session, and I think the whole spectrum of onconephrology is very exciting. Definitely, we encounter a lot of renal issues when dealing with cancer patients, from simple things like chemotherapy and how we adjust dosages in renal failure. Remember the patient we discussed earlier on who needed chemotherapy and was a transplant recipient. And then now moving over to the actual tumors that threaten the kidney, renal cell carcinoma, urothelial cancers, adrenocortical malignancies, the whole influx of immunotherapy and TKI. It's a very, very exciting new field. I'll just make a few comments about renal cell carcinoma and the outcomes that have really changed since we started using a lot of TKI immunotherapy combinations. And these patients are actually living longer, and we're turning RCC more into a chronic disease, and patients are actually living longer. I'm sure a lot has been said. I don't want to say so much, but I'm just quite honored to have listened to the speakers. I've also learned a lot, and we should have more sessions like this. Thank you.
Awesome. There are two questions. Khalida, are you still around? Or
It looks like she might have dropped off.
okay. So while we wait for her, there was one question, and I'll paraphrase here in view of time, is there's a 50-year-old who was diagnosed with myeloma, bone marrow confirmed. Would you consider a kidney biopsy in the setting of AKI, creatinine of 3.2 and 5.6 grams of protein over 24 hours?
Is this I'm gonna just give some scenarios here. So with someone who's got confirmed multiple myeloma, there are other renal diseases that occur with it. So I would, after resuscitating the patient and optimizing them, and then treat them for their multiple myeloma and watch, and you should get a reduction in the renal markers. If you're not winning, then I would do the kidney biopsy. So I wouldn't rush in straight away. The question is going to be the timing of the kidney biopsy. That I think is going to have to depend very much on the clinical state of the patient, what's happening, is there a bit of tumor lysis syndrome happening, there's so many variables there. But at the end of the day, you're going to have to look and see what's best for the patient, chat to them and say, look, I'm not sure it could be this, or this. And then I would say the risk of a biopsy of bleeding in your disease, it's usually about 4%. It depends. It's also site specific. and say, this is the risk, this is the benefit, and then take it from there. And it's also kind of in this gray area where it depends on your funders as well. In South Africa, we've got a public and a private system. In the public sector, we can, it's, I hesitate to say it, but it's almost like a free for all. You can do whatever you want, but yeah, it's not quite that way. And then in private, you have to fight with the funders to get the procedures done. So there's no straight answer, unfortunately, but I would wait before doing a biopsy in multiple myeloma initially.
Awesome. I think Kalida's back.
Sorry about that.
Sorry about the electricity.
Just flickered. Oh wow, that's okay. But I think we have an attendee who's had his hand up for a while, and that's Dr. Abdullahi. And Abdullahi, are you able to unmute yourself and maybe just ask your question? Yes, Dr. Abdullahi, you may proceed.
Yes, I have unmuted myself. Good afternoon.
Afternoon.
Yeah.
Afternoon.
You had a question?
Yeah, actually, just an appreciation, as I mentioned in the comment box. When my trainer have sent me this symposium, I was quite happy that to see that there is this collaboration in Africa. As I have said, I've been looking for some literature about onconephrology in specifically Nigeria and in Africa, but I couldn't find any. Even some literature that I could find, they are very scarce, even from the West. So this collaboration in Africa, I think is a good one. So it's just an appreciation. Thank you.
Thank you, Doc. Thank you so much. We really
Very kind
appreciate
of
it.
you.
Yes. So I will now move on, I think, to our next speaker, and that is Dr. Ugochi Chika. Ugochi is my colleague and great friend of the Young Nephrologists group of the African Association of Nephrologists. She's a consultant physician and nephrologist at the University of Nigeria Teaching Hospital in Enugu State in Nigeria. She is very deeply involved with the International Society of Nephrology as a coordinator for the ISN Sister Renal Center program with the George Institute for Global Health in India, and coordinator of the Sister Renal Center program with Krutusku Hospital in Cape Town. And she's a member of the ISN Interventional Nephrology Working Group and a member of the ISN African Regional Board and an ISN Emerging Leader, Ugochi. And she's also the chairperson for the YNC under the Nigerian Association of Nephrology and a fellow of the West African College of Physicians, who is involved in all aspects of nephrology, but she also notes that she's a neonate in onconephrology. But beyond medicine, we know Ugochi is a dedicated mom of 4. Ugochi, where are you? Ready to share your slides?
Yes, I'm ready to share my slides. Thank you so much for your time.
Ugochi, can we hear you?
Can you hear me?
Pooja, can you hear Ugochi? Perfect. We can see your slides.
Can you hear me?
Yes, we can hear you well. Take it
Okay.
over.
So thank you for the kind introduction. And like I said, I'm a neonate in this field, and I was told to do this in 30 minutes. I hope I will not be too fast. I talk quickly. So we're looking at chemotherapy and nephrotoxicity. I have no conflict of interest to disclose. And I have a very brief outline to last for 30 minutes. So chemotherapy nephrotoxicity actually arises in situations where the clinician is trying to do good to the patient who has cancer by exposing him to some drugs, but the patient ends up developing complications. So we start this lecture by joining Sir Robert Hutchinson to make this prayer. From inability to let well alone, from too much zeal for the new and contempt for what is old, from putting knowledge before wisdom, science before art, and cleverness before common sense, from treating patients as cases and from making the cure of the disease more grievous than the endurance of the same. Good Lord, deliver us. The fight against cancers has led to the discovery and development of many drugs, which have led to reduced tumor progression, increased patient survival, but fraught with complications. One of these complications is nephrotoxicity, which is a rapid decline in kidney function due to medications or chemicals. About 80% of cancer patients are known to be exposed to nephrotoxic drugs. And this is a serious problem because it will affect drug prescription, adherence, efficacy, treatment outcomes, and in most cases, dose adjustment or even treatment stoppage. Being an excretory organ, the kidney is at increased risk of toxicity from these drugs. And nephrotoxicity affects all the 4 principal histological kidney parts, including the glomerulus, the tubules, the interstitium, and the microvasculature. So this slide tries to show that every part of the nephron can be affected by nephrotoxicity, and including the vascular components, the glomerulus, the interstitiums, and all the parts of the tubules. I want to present this case, which I termed a nephrologist frustration. This is a real patient that we are currently managing. He is Mr. N.A., a 73-year-old retired professor who was diagnosed with glaucoma in 1992, hypertension in 1993, CKD in 2012, and BPH in 2018. He, however, remained stable and had controlled blood pressure with a creatinine ranging from 201 to 234 micromoles per liter. But in 2022, he developed right-sided blindness, and in 2023, he developed an unremitting severe right eye pain and tearing, which led to the diagnosis of neovascular glaucoma. He received intravitreal 1.25 milligram of bevacizumab and intravenous mannitol. His right eye pain resolved, but it reoccurred in May 2023, and he received the second dose of the same medication. A week after this, he developed bilateral leg swelling. He had no obvious CVS or GI symptoms, but reduced urine output and increased urine frothiness were noted. His blood pressure also rose to 160/90 millimeters of mercury, and some medication adjustment was done. But because he had recurrence of this right eye pain, he further received more doses of bevacizumab and mannitol. He subsequently developed oliguria, anorexia, weakness, and worsened body swelling. His creatinine rapidly increased, and a new onset anemia, microscopic hematuria, and worsening existing proteinuria were noted, hence his referral to us. So when he presented to us, we evaluated him and had a suspicion of bevacizumab-induced AKI, which could be collapsing glomerulopathy or thrombotic microangiopathy, and we wanted to biopsy this patient. Unfortunately, his subsequent investigations discouraged kidney biopsy. Patient and his caregiver, however, decided to opt for a trial of steroid and suspension of further administration of bevacizumab. In January 10th this year, he received a post-steroid and subsequently followed up on daily oral prednisolone. He made an initial improvement, but in March 2024, the excruciating right eye pain recurred, and he had to get another dose of bevacizumab, this time around without mannitol. But he still developed body swelling, reduced urine output, and in April 2024, he developed uremic symptoms and anuria, and hemodialysis was subsequently commenced. And he's currently stable, receiving 2 times weekly hemodialysis. So this patient is a real patient, like I said, even though he wasn't being managed for a malignancy, but he was exposed to chemotherapy and he developed acute kidney injury. Not everybody who receives this drug actually develop acute kidney injury, but there are some circumstances and conditions which will increase the patient's risk of developing this condition. And these will include older age, as we saw in the patient we just presented, who was 73 years old, female sex, A pre-existing kidney disease, just like we found in our patients who had stable CKD since 2012. Comorbid conditions like hepatic failure, especially when there is concomitant hypoalbuminemia, in which some of these drugs, which ordinarily should be protein-bound, are freely circulated in circulation, increasing their concentration and, of course, increased risk of toxicity. Diabetes mellitus, hypertension, and as in general population, sepsis and volume depletion are all risk factors for kidney disease themselves. And when they also trigger kidney disease and acute kidney injury, they increase the chances of patients being exposed to cytotoxic drug to having nephrotoxicity. There have been a lot of discussions about genetic contribution to nephrotoxicity, especially as regards hepatic and renal cytochrome P450, which regulates the metabolism and excretion of these drugs, and of course, the activity of renal transport proteins. The nature of the malignancy is also important. Like we found in our patient, even though it's not a malignancy that is being managed, he has a recurrent condition, which means from time to time, there is a chance that he will continue to be exposed to these nephrotoxic drugs. There are some therapy-related risk factors, and these include the nature of the therapy, including the types of drugs. Many drugs have been shown to be more nephrotoxic than others. For instance, cisplatin has been recognized to be one of the most nephrotoxic cytotoxic drugs in use. The duration of the treatment, the rate of treatment, the frequency, as well as the route of administration have all been documented as risk factors for development of nephrotoxicity. In the patient we presented, uniquely, he didn't get intravenous drug that we expect to increase the risk of nephrotoxicity. However, many literature have documented that intravitreal injection of bevacizumab has been associated with kidney injury. Some investigations that these patients are meant to undergo, like contrast investigations, have also been known to increase their risk of having nephrotoxicity. Concomitant use of other nephrotoxins drugs, including diuretics in this setting, ARBs, ACE, the NSAIDs, some antibiotics like aminoglycoside, antivirals like acyclovir, when they are used concomitantly with anti-cancer drugs, they have been shown to increase the risk of kidney injury. There are also some drugs which may not be inherently toxic to the kidneys, but interfere with the ability of the kidneys to secrete drugs and subsequently eliminate them renally. And these drugs include cimetidine, trimethoprim, and pyrimethamine. So their use should be put into consideration when you are prescribing for patients, including the need for dose adjustment. Drugs that have insoluble parent or metabolic compound are also known to have increased risk of toxicity. The reason being that they are more likely to precipitate within the renal tubules, and they may be directly toxic to the renal epithelial cells or cause intratubular obstruction, and of course, AKI ensues. One of the consequences of exposure of patients to cytotoxic drugs is tumor lysis syndrome, which has been defined as a constellation of clinical signs and symptoms arising from the release of intracellular contents of neoplastic cells into the circulation, and usually occurs between 4 to 72 hours after initiation of cytotoxic therapy. However, it has also been shown to occur spontaneously in patients who have high-grade hematological malignancies, including non-Hodgkin's lymphoma, acute lymphoblastic lymphoma, diffuse B-cell lymphoma, and patients who have very sensitive, chemosensitive tumors. It comprises of hyperuricemia, hyperkalemia, and hyperphosphatemia, all arising from the release of the contents of these tumor cells into circulation. As this occurs, the high uric acid will be broken. The purine is actually broken down by xanthine oxidase, hepatic xanthine oxidase, to form uric acid, and this can be found in the circulation. Hyperkalemia, we know that potassium is generally a more intracellular electrolyte. So when you have lysis of cell, the intracellular potassium is sent into circulation and you have hyperkalemia. The same goes for hyperphosphatemia, but alongside the hyperphosphatemia, it binds to serum calcium and forms calcium phosphate stones, which can be deposited in the skin, other tissues, including the kidneys. So in the midst of this is acute kidney injury, which could come as a result of so many issues. But just like what we just discussed in the previous slide, it could come from uric acid crystal formation, which can cause intratubular obstruction, together with calcium phosphate crystal. It has also been noted that hyperuricemia is a potent vasoconstriction inducer. And when it causes vasoconstriction in the renal bed, it impairs renal autoregulation and subsequently impairs renal perfusion, leading to acute kidney injury. The risk factors for tumor lysis syndrome will include, like we mentioned, high-grade hematological malignancies, advanced age, presence of pre-existing hyperuricemia, hyperphosphatemia, and hyperkalemia in a patient before the initiation of chemotherapy. A patient who has a pre-existing kidney disease, previous AKI, current CKD, has increased risk of this condition too, because these patients have limited ability to excrete, renally excrete some of these drugs. So they stay longer in the system, are able to act longer, and also attain higher concentration. Exposure to other nephrotoxins, like we said previously, will worsen cause AKI, and when AKI occurs, renal excretion of these drugs reduce. And of course, volume depletion and oliguria have also been implicated. But we note, unfortunately, that tumor lysis syndrome is likely to occur when we have effective and well-targeted anti-cancer therapy. That is actually ironical. So patients can have reduced urine output, hematuria, flank pain, especially when there is deposition of either uric acid stones or calcium phosphate stone. Of course, fluid retention is not unexpected as they have intratubular obstruction, or they can have acute injury with oliguria or even anuria. In the presence of hypocalcemia, nausea, vomiting, paresthesias, including perioral paresthesias, can occur. These patients can have seizures and tetany. Patients who have calcium phosphate deposition in the skin will have pruritus. When these stones are deposited within the joints, you can have arthritis. And of course, when they are deposited in the renal parenchyma, nephrocalcinosis is observed. Hyperkalemia presents with weakness, paralysis, palpitation. Of course, patients can have syncope and sudden death due to cardiac arrhythmias. And in the presence of hyperuricemia, lethargy, nausea and vomiting, arthralgia when you have uric acid stone deposition within the joint spaces, and of course, renal colic when you have uric acid stone deposition. Uremia can also occur when acute kidney injury progresses in the setting of tumor lysis syndrome. Prevention is the key for tumor lysis syndrome because you do not have definitive management. What you have generally is supportive care. Early dictation is important. So this points to the fact that patients should be on monitoring before, during, and after initiation of therapy. As it has been noted, tumor lysis syndrome is more likely to occur within the first 48 to 72 hours after initiation of therapy. And when it is detected, investigations are mandatory, including serum electrolyte and creatinine, looking out for electrolyte imbalances, including hyperkalemia, looking for hypocalcemia, looking out for hyperphosphatemia, and of course, metabolic acidosis. ECG monitoring is essential to detect arrhythmias and need for intervention in cases of hyperkalemia and hypocalcemia. The management of hyperkalemia and hypocalcemia in this patient is similar to what we do in the general population, which include stabilizing the myocyte, as well as driving potassium back into the cells using either the sodium bicarbonate or glucose and insulin regimen. Of course, when this fails, elimination using dialysis could be also used. It is also important to manage the pH of, monitor the pH of this patient. Like we said, we are worried about intratubular obstruction from uric acid stones and calcium phosphate stone. And we know that uric acid stones are more likely to precipitate in acid urine, while calcium phosphate stones are more likely to precipitate in alkaline urine. The correction of metabolic acidosis actually is controversial. The reason being that although it can help with management of hyperkalemia, it will also increase uric acid solubility. It will increase uric acid insolubility. And as we know, the more you give your sodium bicarbonate, the more alkaline the urine becomes, which implies while the uric acid stones will dissolve, your calcium and phosphate stones will increase. Hyperuricemia management is also, like we said, similar to the general population, but the use of xanthine oxidase inhibitors, especially allopurinol, is preferred. However, allopurinol is fraught with complications, including rash, acute interstitial nephritis, fever, eosinophilia, and others. Febuxostat is gradually coming up the ladder because of the fact that renal adjustment is not really indicated. The diet of these patients should be controlled, especially to eliminate diet that is rich in potassium and uric acid. And in our setting, we try to eliminate high potassium fruits like citruses, bananas, and of course, red meat is avoided in this patient to prevent worsening of hyperuricemia. Phosphate binders are indicated for hyperphosphatemia, similar to what we do in the general population. And although in Africa or in Nigeria, we have more prevalence of calcium-based phosphate binders, but the non-calcium phosphate binder like sevelamer is preferred, especially if the patient is going to be on these drugs in a long term. And of course, indication of dialysis in this group of patients is similar to what is done in the general population. Besides tumor lysis syndrome, other things can occur when the patient is exposed to chemotherapy, and this will include rising creatinine level, azotemia, proteinuria, which could be subnephrotic or nephrotic. It could be new onset proteinuria or worsening of pre-existing proteinuria, as we mentioned in the patient that we presented. Acute kidney injuries can occur, including thrombotic microangiopathy, which is suspected in our patients, acute tubular interstitial diseases, and of course, crystal nephropathy. And we said oftentimes we are looking at uric acid stones or calcium phosphate stones. New onset hypertension or worsening of pre-existing hypertension, like we saw in the case we presented, have all been documented, especially in those substances that are capable of giving endothelial injuries. Acid-base disorders and electrolyte imbalances, including Fanconi syndrome, have all been documented, especially when there is proximal tubular injury. Different forms of chronic kidney disease can ensue when the acute kidney injury is not properly handled or does not resolve. And the glomerulopathies that have been noted in these settings include focal segmental glomerulosclerosis, focal global glomerulosclerosis, minimal chain disease, membranous nephropathy, and of course, chronic thrombotic microangiopathy and chronic tubular interstitial diseases. And of course, progression to kidney failure can also occur. So this table tries to bring out the various cytotoxic drugs that cancer patients are exposed to, and also some of the drugs we use as nephrologists to treat various kidney diseases, including glomerulonephritis. And we can see clearly here tubular injury, glomerular injury, thrombotic microangiopathy, Fanconi syndrome, proteinuria, acute kidney injury, and tubular interstitial diseases. And you can see our tongue-twisting friend, bevacizumab, appearing in most of these columns. This is also a very busy slide, and it tries to look at the various classes of cytotoxic agents and the different nephropathies that they can occur. So if you look at this, like I mentioned earlier on, cisplatin has been noted to be one of the most nephrotoxic cytotoxic agents being in use. And it commonly starts with acute tubular injury with associated Fanconi syndrome, which will result in wasting of electrolytes, amino acids, glucose, and whatnot. Down there in the table, we see the alkylating agents, including our commonly used cyclophosphamide for many of our patients with GN. And you can see it is associated with tubular damage and increased oxidative stress. And we move down a little bit to look at the antimetabolites, including methotrexate, that is also commonly used. And you can see its principal presentation is crystal precipitation. So you can have formation of crystals and intratubular obstruction. At the last column in this table, we are looking at the vascular endothelial growth factor, where our dear tongue twister friend, bevacizumab, is. And you see they cause direct endothelial and podocyte injury. Little wonder then that the patients can develop hypertension, proteinuria. But if you look at the column of management, you will see that there's really no specific management for any of these nephrotoxicities. What you see is hydration, reduction in dose, or even stoppage of treatment and other supportive therapy. Management of hypertension using ARB and ACE have been suggested, but it's not that there's a controlled trials for this. This actually stems from the application of use of ARB and ACE in management of hypertension and proteinuria in general public. But remember, in the setting of acute kidney injury, it is best to stay away from ARB and ACE as they could worsen the patient's acute kidney injury. So we look at our friend again, the vascular endothelial growth factor, the anti-inhibitors. So we see that one of the things they can do when they block up the vascular endothelial growth factor is they will reduce lymphogenesis, which means the lymphatic drainage will be impaired. And this is one of the pathophysiology of fluid retention in this patient. And we remember that in the patient we presented, he quickly developed leg swelling. So it may not necessarily be because of acute kidney injury, but because of reduced lymph drainage. And you see there's reduction of nitric oxide, which we know is a potent vasodilator. And as such, you have increased activity of vasoconstrictors, reduced vasodilatation, increased systemic vasoconstriction, and of course, culminating in hypertension. Like we said, there's no specific management for most of the presentation that these patients will have. So prevention is key. And in prevention, you need to have adequate risk/benefit assessment. And at every point in time, you need to carry the patients and their relative along to be able to understand the implications of treatment or lack of treatment. There might be need for treatment modifications, including right timing of treatment. For instance, if patient has already existing acute kidney injury or is having hyperkalemia, hyperuricemia, or whatnot, it is best that you correct this before you go on to initiate therapy with anti-cancer medications. Wise choice for drug combinations should be done. And of course, those adjustments were indicated, or even withdrawal of the drugs if complications arise. It is also worth noting that we should avoid co-administration of nephrotoxic drug with this cytotoxic drug because, like we said, they will potentiate their nephrotoxicity. Adequate hydration cannot be overemphasized, and it has been advocated that for a patient that you are trying to initiate on anti-cancer therapy should be able to make at least 3 liters of urine per day. And of course, close monitoring to enable early detection and prompt initiation of therapy is advocated. So we have to appropriately manage the patient and then rule out all other non-chemotherapy related causes of acute kidney injury. And the commonest in this setting is dehydration. So if the dehydration is detected or any other condition is detected, hypertension, these things should be managed before we lay all the blames on our dear cytotoxic drugs. Relevant investigations should be done, which will help to check things like the level of toxicity, the level of urea and creatinine if they are rising. And of course, you're also looking at the urine. What are the things that you find in the urine? Activities, proteinuria, hematuria, and all that. That could be indicator that it could be this drug or it could be something else. And as such, kidney biopsy comes into play. The last presenter tried to make a case for times when you need to do kidney biopsy and times when you do not need to do kidney biopsy. And as a rule of thumb, the indications of kidney biopsy in this setting is similar to indications of rule of kidney biopsy in the general population, in which case, if you have an identifiable cause of acute kidney injury, for instance, dehydration, sepsis, heart failure, and all that, you need to handle this instead of jumping straight to kidney biopsy. But when the issue of diagnosis comes up, and in the case of our patient, it's really a pain that we couldn't biopsy this patient, because even if we are concluding that bevacizumab is responsible for his kidney injury, it could be a lot of presentation. It could be acute interstitial disease, it could be collapsing glomerulopathy, and it could be a TMA, and in which case the treatment plan could have been altered. Of course, rehydration, the use of antihypertensives to control hypertension, management of electrolyte abnormalities, use of antioxidants, and other adjuvant therapies have all been advocated, but with little evidence to support them. Dialysis is indicated just like in general population. So in summary, we are saying that despite improving cancer patient survival, anti-cancer drugs are fraught with kidney complications ranging from acute kidney injuries to chronic kidney injuries and progression to end-stage kidney disease. Unfortunately, The exact mechanism of most of these renal injuries are still vague. Therefore, more studies are required to be able to elucidate the pathways of these injuries and be able to proffer treatment. And one of the person commenting in the last question and answer session was emphasizing the fact that there's no data in Africa. Yes, there's no data in Africa. So it's a challenge to you and me to go back to our centers and begin to do the work. There's also a need for thorough treatment risk and benefit assessment with the person's consent. And as a general rule, adequate hydration, avoid cold nephrotoxin administration, dose adjustment, drug withdrawal when indicated, close monitoring, and early detection and prompt intervention. And because we still maintain that we do not want to cause harm to our patients, we end this lecture by still making the second part of Sir Robert Hutchinson's prayer. From making the cure of the disease more grievous than the endurance of the sin, good Lord, deliver us. Thank you for listening.
Thank you so much. Oh, Ugochi, I think you took less time. Thank you so much. And I think as you talk about it, the thing that comes to mind is what you say, the benefit versus the risk, and the concept of therapeutic nihilism in CKD. And I don't know, I can see Professor Sridhar here, and that's perfect for us to be able to have this discussion. I don't know what you talk to your patients about, Prof. Ugochi, Prof. Pooja, in terms of benefit versus the cost, because more often than anything, what happens to our patients immediately, creatinine is a little bit raised, GFR is a little bit deranged. Everybody is like, oh, we can't do anything because of the kidney function. Well, what would your response be to them, Prof. Sridhar?
We do lots of things here for our patients, and it's often a very much an individualized conversation. So I spend a lot of time talking to patients and family members to try and understand their goals of what they want to accomplish from this, right? Just because we can do something is not necessarily the right thing to do, or you should do it. This is a really good lecture from Dr. Ugochi, and I love Robert Hutchinson and the quotes. I went to med school in India, and it was the first page of our book, so we memorized it. I try my best to do that. Sometimes I don't think I succeed, but we do the best we can. Pooja, did you have any thoughts?
Yeah, absolutely. No, I think you summarized it so beautifully that, this is such an individualistic approach, and talking to them about what their goals are and, what a reality for them would be. I think it's very important. And as, the survivorship issues of cancer go on, I think this is going to be a more important and mainstream conversation as we go along. And that was such a great talk, Ugochi. Thank you so much.
And Ugochi, I understand the conundrums that you go through, actually, because for us socially, these are not conversations that we can actually have with our patients. We still have very paternalistic medicine. I'm not sure how it is for you, Ugochi, in Nigeria, but many times patients will tell me, you make the decision. And palliative care is unheard of in Kenya, and everybody is like, yes, but treat the so Ugochi, how is it for you in Nigeria? Are people open to a conversation about palliative care and advanced directives, or a conversation where we have mutual or shared decision making with the physician? How do you find it? We can't hear you well.
Oftentimes the oncologists actually bring us in when they have patients that have renal impairments and they want to initiate drugs. So for those patients who don't even have renal impairments, who have other risk factors that we could have dictated, we don't really get early on involved until complications arise. So that is a bad one. That's number one. Then number two, in terms of treatment versus palliative, actually for us here, the main determining factor is money. For patients who can afford their care, they will ask you to go ahead and do whatever you can do to prolong their lives. But for patients who cannot afford the care, of course, palliative medicine becomes the issue. And then, of course, you do what you can do, cancel them and just buy as much time as possible for them. So generally, everybody wants to live, but money becomes the defining factor.
It's tough decisions to make. I know I've seen Andrew himself very often talk to our patients about an advance directive, pull me in because of CKD. And now we're trying to have this conversation where we're like, okay, you could end up on dialysis if we do this. And, but because we already have deranged renal functions, and what is the cutoff? Where at what point do you say, I'll do this and I won't do this? So it's really tough. I think
I'll just make a small plug-in, and this is something that I think I have the hardest time with. And as cancer becomes a problem of the younger population, sometimes these patients can be their bread earners of the family. Like, you guys will not believe, but I have a patient that I saw actually last afternoon who is on the 4th line of DLBCL, and he developed really bad toxicity from gemcitabine, and he's like, I took up a new job because I have to support my family, and I, cannot stop working. So as this gets on to even, and he's just 49. So, these are such heartbreaking conversations for me. And all I could say is I'm so glad that you're not on dialysis, because that would be one additional barrier for him to have a functional, life of some sort. So yeah, I think that's it's a very interesting landscape, to say the least, to manage these very, very niche patients. And now it's not even so niche, and unfortunately we're going to see more of these. So it's it's good to have colleagues to have these conversations with and learn from everyone's experience.
Actually, there is a really nice question by Dr. Okafor on the Q&A.
Yes.
What is the least level of creatinine or GFR to approve cancer chemotherapy if the oncologist refused to start therapy for renal impairment? I don't know the answer to the question, right? I mean, it is between two bad choices, and that's what I tell my patients. Yes, you have impaired kidney function, but if we don't give you the chemo, you're going to be dead. And life on dialysis is not spectacular, but at least you're alive, and maybe we can do peritoneal dialysis. Maybe we can do medical management of advanced kidney disease to keep you off dialysis. I'm a lot less of a nihilist than I was 4 or 5 years ago, because I now work mostly in an onconephrology center, and almost all of my patients have CKD and cancer. So while, yes, dialysis is not the most beautiful solution, it's maybe slightly better than being dead.
That is so true. And I think my view is also like that now, dealing 90% with onconephrology patients, that, it's better to be present. And for some patients, it's like their goal, like maybe their kid's graduation, or maybe they're, seeing their grandkid or something like that. So yeah, I've become definitely more sensitive about their needs too, keeping that in mind.
In settings where dialysis care is not free or guaranteed by the government, I think the economics of all of this becomes a lot more complicated, and then really is individual choice. But I know a lot of my pediatrician in India who took care of me went on dialysis, and after some time said, this is costing me too much money, and he stopped. So it's,
I think that's the reality of it. That's the reality of it. But I also have a patient who about 10, 12 years ago got adriamycin for a tumor, and then she developed heart failure that led to cardiorenal syndrome. And that's really, so now she's on dialysis. But you know what? As you say, Pooja, she's alive. And now we're talking about transplanting her. Yeah. And she's now 2 years old. And at that point, when this was happening, she was about 40, 42. So I guess these are the conversations. But as you say, Prof, it's in the background of our government is supporting hemodialysis. So these are conversations that we can actually have. And I see another question that the two of you can help me answer here. For patients on dialysis needing chemotherapy, how is it best to schedule the two? Would you have your dialysis and then give your chemo after? What happens with that? Dialyze before chemo, after chemo? What do we do about that? Because I think that's a very practical question.
So it depends on the chemo. I think my recommendation, so we are lucky to have a pharmacist that helps us manage some of these issues. But usually if it is small molecule, water soluble, then you're going to administer after dialysis, because you don't want it to get dialyzed out. If we're giving some large molecule monoclonal antibody for immunotherapy, then it mostly is based on fluid volume status. So usually we reduce dose for people with eGFR less than 15 and that are needing to go on dialysis, and we typically administer it after dialysis to make sure that we don't suck out any of the good stuff that we gave them. But it is definitely something that you will need some help and advice from pharmacy if it is available.
Yeah, that's the same practice with us as well.
And Ugochi, directly from your presentation, I see Amir Muse, who is an ISN fellow, actually, Amir, if I'm not mistaken, from Somalia. How is it possible to hydrate patients with a urine output of more than 3 liters when many times the patients are already fluid overloaded? And I think that's just a practical question. And coming again from a background of we don't have renal replacement therapies just very freely available. Ugochi, what would you say about this?
First of all, we're talking about the desired versus reality. So when we're talking about that adequate rehydration, in fact, most people will project that it's ideal to admit some of these patients like 3 days before time and start the rehydration. It's not like you are starting drugs and you just give patients, because for you to actually achieve 3 liters of urine means you've already given more than 3 liters plus taking care of insensible loss. So this is actually what we would want our patients to have. So someone who has good renal function and is taking enough fluid, and you have, maybe you gave extra 2 liters of normal saline, that person is definitely going to excrete that 2 liters of normal saline. But when you already have patients who is having fluid retention, that means there's also a renal impairment and you want to start cytotoxic drug, you're going to make matters worse. So it's even better for you to handle these things than rushing to go and give the person drug. But again, like you said, we will always say, it's an individualized thing. For instance, even when we're talking about this 4 or 5 liters of fluid in a day, and someone has cardiac impairment, you know the person is not going to get that. So it's something that you as a nephrologist will sit down and see what the person can stay. And you also know that generally in management of acute kidney injury, that rehydration is key to a patient's therapy. But there is also exclusions. Like we said, if patient has fluid overload, it cannot make matters worse by giving more fluid, because you end up overloading the heart, and the person will not only battle with the kidney, but you also battle with the heart. So it's something that you should individualize. But if your patient is right, is taking enough fluid, that should be your target. Because the reason for this is, it's been shown that people who make up to 2 to 3 liters of urine in a day have less chances of having urine stasis, and in such settings have less chances of having uric acid stone formation or calcium phosphate stone formation, which we mentioned are things that bother us in patients who have tumor lysis syndrome.
Ugochi, I think we will leave it at that point, and I love the take home, which is treat the patient who's in front of you. I'll hand over now to Pooja. Pooja, let's move on to our next.
Thank you for having me on the call.
So much, Ugochi. I just enjoyed that presentation. Thank you so much.
Yeah, thank you so much for the presentation. And this is a very nice segue into our next speaker and our next talk. And that's Dr. Sridhar Mandaya. And he's a vice chair of Baylor College of Medicine at Houston, Texas in the US from 2016 to 2018. And he's also a member of the Baylor College of Medicine, Einsberg Institute of Clinical Decision and Communication Sciences at Houston. And he continues to be at that position. Currently, he completed his medical school in Bangalore, India, then followed it up by an MRCP in London, and then an internal medicine preventive care residency and nephrology fellowship at University of Texas in Galveston. His research interests are in Mesoamerican nephropathy, nutrition in cancer and CKD, tumor lysis therapies, and he's very active in clinical trials and leading a research center over 100 clinical trials. He is an investigator at the Prolado Clinical Research Center, with his main interest being healthcare innovations, spearheading potential solutions and ideations to testing and subsequent delivery, developing either like being an angel investor or a seed to a series phase.
Oh my God, my introduction is longer than my talk, Pooja, enough.
Yeah. So in brief, he does a lot of clinical work to help patients and really come up with really nice healthcare solutions for it. So without further ado, Dr. Mandayan from MD Anderson will talk about cancer and nutrition in these patients with CKD.
Those are all things you just write on CV to make it look impressive. I'm just another kidney doctor like all of you here, and it's wonderful. So happy that all of you are staying up late and listening to us talk. I will promise not to keep you away from dinner. I only have about 10 slides. Khalida, am I presenting or is somebody on your side presenting?
I can present. Do you want to present?
Can you present, please? Because I might screw it up.
Sharing right now.
Okay. But, you know, so just as an introduction, when I was doing my fellowship and then subsequently in my first faculty positions, I worked with this nephrologist called William Mitch, and he was the president of American Society of Nephrology, and he spent a lot of his time looking at muscle protein wasting and catabolism in patients with kidney disease, and whether we could do nutritional therapies to improve kidney disease catabolism and maybe even use nutritional recommendations to prevent patients with CKD from progressing. So I'm a big fan of something that is fairly controversial, which is putting people with advanced kidney disease on low protein diets. I personally have taken care of many patients where we have delayed their transition to dialysis by years by nutritional management. And I think that this is something that we don't pay enough attention to. Fortunately for me and unfortunately for all of our patients, there is hardly any evidence on this in the subset of patients with cancer. So it is a wide open field. And if there are young trainees, fellows, people that are trying to see what do I want to do for the next 10, 20 years of my life doing research or career, then this is probably a great opportunity. Next slide, please. This whole presentation came up as an idea for a paper. So the editor of the Journal of Renal Nutrition, who is a friend of mine, reached out and said, hey, Sridhar, you take care of patients with CKD and cancer. Is it possible for you to put together like an opinion piece editorial on how to manage patients with CKD and cancer and see if there are any nutritional recommendations? So like any good professor, I reached out to all of the people I knew that had any interest in this field, and we put together a group of dietitians, mostly working at MD Anderson and the VA system right next door, that are very, very eager to help put together some data, maybe come up with some recommendations because they realize that there are a lot of patients, not enough evidence, and maybe there is a good thing we can do here by generating some instructions and rules. Next slide. So these are my collaborators. This would not have been possible without them. Victoria and Diane, everybody else. And obviously, you don't need me to go through all of this again for the last 2 hours. People have talked about this. Fortunately for our patients, cancer is turning into a chronic disease. It is not something that you die of immediately. You die of it from years, maybe after recurrence, after stem cell. Unfortunately for our patients, because they don't die immediately from cancer, because they live longer, a lot of them seem to be developing chronic kidney disease. We have pretty good guidelines for nutrition in CKD. We have pretty good guidelines for nutrition in cancer, but we have absolutely no guidelines for patients that have a combination of cancer and chronic kidney disease. Next slide, please. Malnutrition, as you all understand, is a very, very big problem. I'm sure you see it in your patients. There is a whole host of reasons that this occurs. In the United States, the bigger problem in healthcare is overnutrition, where people are obese and people are not taking the right kinds of food. But when they come to see me in CKD clinic after cancer, it's often the opposite. They have inflammation, they have gut dysbiosis, their microbiome is abnormal because we've given them all kinds of chemoimmunotherapy. A lot of our patients are developing mucositis, gut motility disorders just from chemo. So on top of that, if they develop uremia and develop metabolic acidosis, they have worsening muscle protein breakdown and loss of muscle mass. So clearly, overnutrition is not an issue. Malnutrition is a problem, whole sort of risk factors, and we're not entirely sure where to intervene. Next step. Next slide, please. So we think that most patients with cancer and CKD need to develop an individualized treatment plan. So I work at MD Anderson and have the good fortune of having renal dietitians that I can refer my patients to so that they can help develop a nutritional plan for our patients. So you need to make sure that they have enough energy for maintaining neutral nitrogen balance. We need to figure out if they need to be on a low protein diet or a high protein diet, depending on the stage of kidney disease, what comorbidities they have, and also most importantly, goals of care. So I'm on call in the hospital. I was just rounding. I saw this lady. She's 78 years old and has CKD stage 3. Her creatinine is 1.2. EGFR is in the 60s. Somebody told her she needs to go on a low protein diet, and she ended up in the hospital with hyponatremia, sodium of 120. Completely avoidable problem. All we made her do was eat some protein, and the next 2 days her sodium came up to 130 and she went home. So it is very easy to be dogmatic about a lot of these things, saying if you have CKD, you need to go on a low sodium diet, low phosphorus diet, low protein diet. But then you need to step back and look at the patient you're seeing, because maybe that is not in their goal of care. Maybe there is no, who knows what the right diet is for an 80-year-old person with cancer. What is it that we're trying to prevent? They're not going to end up on dialysis. You might as well let them eat and drink and live a normal life. So it is very important to individualize a treatment plan. It's very important to connect with a nutritionist or a dietitian that can help develop a strategy for your patient. This is not a very resource intensive thing. It's not an expensive thing. You don't need, there's no scans needed here. There's no monoclonal antibodies, no special tests. All you need to do is sit down with your patient, have a dietitian, and figure out how to help them eat for their goals, eat better. Next slide, please. So for sure, there is a lot of evidence saying that putting people on plant-based diets is good for patients with advanced kidney disease. There is now developing increased evidence that putting people on plant-based diets is also good for cancer response and chemotherapy. So there's some evidence that gastrointestinal fiber content improves immunotherapy response. We know that if you alkalinize food, you can reduce hyperkalemia. And also there is a lot of data saying that micronutrients that are obtained from whole food sources rather than from a pill or from an infusion are much, much better. And one of my pet peeves, and I think this is more a Western problem, I don't know for sure, but supplementation is a huge issue here in the United States. Next slide. A lot of my patients end up taking enormous amounts of vitamin D, vitamin E, vitamin A, because somewhere they read on the internet or Google that it will prevent your cancer or cure you from something. So we get patients with vitamin D intoxication, hypercalcemia, even needing dialysis sometimes because they went on the internet and found something that they think will help them. So it's a huge issue that needs to be addressed. And my recommendation to all of my patients is don't put anything into your mouth unless you talk to me, because it may be good for somebody else, your aunt or your cousin, but for sure is not a good thing for you. So do not supplement unless you have some clearly proven deficiency or there is some evidence that it might actually do something. Next slide, please. We love to restrict people with various kinds of things. All of my patients end up on a salt restriction, sodium restriction, phosphorus and potassium restriction. There are certain situations where, yes, this is important, especially if your patient has tumor lysis or they're having profound metabolic acidosis from diarrhea as a consequence of some treatment that we've given you. But again, I caution putting people on all these restrictions, especially if they have advanced cancers, they are on the 4th or 5th line, and they have less than 6 months to live or even less than that. So I sometimes wonder, who are we making happy by restricting somebody's phosphorus or restricting somebody's sodium? Half my list in the hospital today is hyponatremia. So a lot of our patients think if they're on restriction, they need to replace it by drinking gallons and gallons of water. So yes, you may have to restrict, but I would say be cautious and individualize it to the patient that you see in front of you. Next slide. Unfortunately, there is almost zero evidence on what the right diet should be for our patients. We all agree that CKD in cancer is an increasing problem. We all seem to have better ideas on how to manage them individually, but for sure, we don't have a good idea on what to do. And there's opportunities here to do research. I'm happy to collaborate with people on this forum. If anybody has some good ideas, then we can figure out a way to work together, maybe come up with some good guidelines to help to manage our patients. And I think that the next one is my last slide, which is just a summarization of we need to know what to do better, and we definitely need to individualize our treatment plans to help our patients. I'm going to stop here. More than happy to take questions. I don't have a lot of answers, but I'd love to hear what people think and what they do in their day-to-day practice. Dr. Swinford, my colleague, is asking a question on, can we switch to plant proteins? And the answer is yes. There is pretty good data that switching to plant proteins are good quality proteins that provide the same nutritional sources and also reduce the risk of acidosis and several other issues. So yes, ma'am, as much as possible. What do you all do for patients for nutrition in CKD and cancer? How easy, difficult to access a dietitian?
Can I ask a question?
Yeah.
In terms of, I mean, I currently have 2 patients, metastatic disease, CKD4, and when we're talking about a low protein diet, I just love hearing you say what you're saying, because I've been doing that for a while and people are 50-50 about it. But, you know, looking at quality of life for patients, sometimes my patients are sometimes elderly, have to travel very long distances to get to a dialysis center. And we're like, you know what, we're going to just make your fistula and you're ready. And we have really low clearance, maybe about 10-9. But they're absolutely fine on medical management. I'm like, when we need to start, we're going to start. But we've been managing them for a couple of years on a low protein diet. So the problem is now in the case of a malignancy, Prof, and what we need is maybe increase our fear is malnutrition, as you say. What happens in that case? Can you still maintain a low protein diet?
So the fascinating part about giving people high proteins, right? In most of these settings, especially in cancer and or CKD, there is no evidence at all that if you overfeed them with large amounts of proteins, they will do better. Your serum albumin, which is some people use as a marker for nutrition, is completely unrelated to the amount of protein in your diet. I have many patients with advanced kidney disease on low protein diets that maintain an albumin close to 4 because their nutrition is adequately balanced. Overfeeding people with protein certainly does not make them better, stronger, capable of taking chemo better, any of those things. All it does is it drives them to a hospital and maybe sticks them on dialysis sooner. So it's a very common conversation I have with my patients saying, Doc, do I need to take this supplement, this protein? I'm like, not at all. Just eat a healthy diet and you're going to be okay. And also this other thing about EGFR and dialysis, I have many patients with creatinines of 7 and 8, EGFR of 5, that are not volume overloaded, not acidotic, not hyperkalemic because they're managing. And we don't even dialyze them. I'm like, there is no reason to dialyze you unless you really have an indication. So I'm a big proponent of conservative management for advanced kidney disease rather than doing dialysis.
And can I ask something else? So in terms of a plant-based protein, the idea is that plant proteins, and here I'm talking about, so I'm going to give you just a personal experience that for us in Nairobi and in Kenya, what our government supports is twice weekly hemodialysis. So our patients are under dialyzed. So many of them on any one time will have a creatinine of about 1,000 plus and ureas of about 30. And hyperkalemia is a major issue. So this is not the ideal situation, but I have found that with my patients here, because of the underdialysis, what happens is that when you encourage them to eat a lot of animal protein, their ureas go through the roof, and they're supposed to be better, but they're actually worse. Their uremic symptoms are just totally unmanageable. And for many of these patients, we'll keep them on sodium bicarbonate even while they are on, just because of the acidosis. So, so there's a patient who's a nutritionist who came up to me and told me, I've been practicing with a plant-based diet. And I'm like, I'm worried because I think that plants will produce more urea because they're supposed to be incomplete, low-quality proteins. And she's like, look, doc, when I don't eat the meat, she's like, I don't itch, I sleep better, my tummy feels better, and in general, my skin's really nice. So I'm like, okay, let's watch this and let's monitor this. And she doesn't have high levels of hyperkalemia. So she actually started changing. This was a few years ago, 5 to 6 years ago. And I feel like the literature is catching up, but she started changing the way that I think with regards to my patients. And what do you think, Prof, and what have you found with this plant-based diet?
Absolutely. So the co-occurrence of hyperphosphatemia and hyperkalemia is much more in animal protein diets than it is with plant protein diets. With some fruits, there is presence of potassium, but fruits also, as long as they are not type 1 diabetic, it actually stimulates insulin release, can push the potassium back into the cells. So the alkalinizing effect and the carbohydrate load can be used for benefit. For sure, plant-based diets and diets rich in fiber and fruits are much more beneficial for our patients with CKD. So the quality of the protein is maybe slightly lower, but not necessarily, depending on how you define quality. I mean, quality here is defined as biological value. So the RDIs that were developed in the United States were many years ago, and they were mostly after World War II. And so a lot has changed now, and the RDIs keep going lower, but day-to-day practice has not adapted. Brew Workin is here, and he and I work with Bill, and so he has a lot more patients than I do on low protein diets. I'm curious to hear what he thinks about low protein and cancer patients, especially with advanced CKD.
Absolutely. I think what you have to say is quite important for this audience. With some limited resources, you got to do your best with the diet and behavior. And so, when you eat animal protein, you're going to produce so many more uremic toxins. So, urea is not the uremic toxin. There's protein-bound toxins, so on and so forth. And a lot of the toxins are actually produced by your microbiome, indican, pea cresol, things like that. And so if you're eating a lot of animal protein, you're producing more of that. And so I think plant-based proteins are more simple and more compatible. And then the salutary effects of potassium, lowering blood pressure, etc. That's good for cardiovascular health. If it's good for cardiovascular health, it's going to be good for the kidneys. And then obviously less acidosis as well. And so I think everything you have to say is within reason. And when we say plant-based, it could be plant predominant or even Mediterranean. So in the standard American diet, the meat is the feature. It's like this big, and then everything else is small. So the Mediterranean diet is flipped, where fruits and vegetables are the mains, and then there's a little side of kebab or something, And so you can, for your patients that can't live without meat, like me, and I think, well, I've seen Khalida eat. She's definitely on a plant-based diet. That's why she's so great.
I'm part Maasai. That does not flow.
Okay.
Yeah, I'm South Indian, so we're all on plant-based diet all the time. So I'm like, what is the controversy? I don't look malnourished by any stretch of imagination.
Yeah. So
Me
the
too.
last
I've
thing
been
I'll say is,
vegetarian all my life.
yeah,
There
you go.
So,
Yeah. So the last thing I'll say is there's a minimum. This is not. We don't have to recreate the wheel. The WHO has already done the trials. So if you're on 0.4 grams per kilo a day, then you have a protein malnutrition. Anything above that is, would be in the range of protein restriction. But absolutely, Sridhar is right. If you eat a lot of protein, it's not going to turn into meat, which is what we want, muscle. And so that's not, feeding someone 2 grams per kilo never helped anyone except raise the BUN and cause hypernatremia and some other issues. So, and then I'll leave this a question for you, Sridhar, which is, can you correlate nutrition with functional status, ECOG score, things like that? And does one feed into the other? Like, in other words, is there interaction where, well, you're more active than maybe your appetite is increased, or is it just a function of the chemotherapy or the cancer?
I think it's sort of more the one-way directionality. If your ECOG score is really bad, then you're probably not going to be hungry and not well enough to eat. So I think that there is directionality, but not causality. It's whatever it is that is causing you to have a poor ECOG score is probably also causing you to have poor nutrition or poor appetite. Force feeding such people with high amounts of protein will not improve their ECOG score or make them better. Definitely not make them eligible for more chemo or get any better treatment. We try all the time because as doctors, we want to do something, right? It's the first urge that we have, but maybe this is not the right thing to do. Dr. Uluchi has a question on what is my definition of low protein diet? Fascinating. We wrote textbook chapters with Dr. Mitch, Biru, and I. So actually, in the United States, the definition is 0.6 to 0.8 gram per kg per day. But that's defined as a low protein diet, but actually in reality, that is adequate protein intake for normal neutral nitrogen balance. So there is nothing low about putting somebody on 0.6 to 0.8 gram per kg per day. That's a normal protein diet. Here, it's considered as low, but it's not true. Here, everybody wants to be on 2 grams per kg per day needlessly. So 0.6 to 0.8 is a great guideline. That's where you should be. 0.4 is probably low. Anywhere above that is not low. Specific food sources from Dr. Okafor. This is a difficult question culturally. I mean, I can give you the South Indian answer. Maybe I can give you the United States answer. So I'm not sure where you're from and what kind of food you eat, but most plants that have decent amounts of protein, like pulses and beans, have pretty good biological value protein without the concomitant hyperphosphatemia and the hyperkalemia that you buy along when you eat red meat or all kinds of meat.
I wish Ogochi was still on and she would be able to answer this question, but I do know that Okafor must be from West Africa, and our patients, the staple diet would have a carbohydrate that consists of corn or cassava, which works, I think, and then you add in your plant-based protein. We are mainly, so the interesting thing, as you say, Prof, is that when I get in my Caucasian patients, I have to actually talk about moderation of protein because they're protein heavy and animal protein heavy. But when I talk to my African patients, I'm like, we will stick to our old diet and we're just going to have a normal African diet, which probably means protein in one meal of the day. If you're lucky, our traditional diet is mainly plant-based, and it's plant-based protein. You'll have beans or legumes or pulses of some form, and you find that most people are pretty okay with that. And I think it would be the same with Dr. Okafor here.
I have another question for Dr. Mandayam, which is, what do you tell your patients when they are interested in a low carbohydrate diet? And the reason I mention this is because some are well read and they are aware of something called the Warburg effect. So the cancer cells metabolize only glucose. So if you starve them of glucose, theoretically, well, the cancer doesn't grow as fast. And so what do you say to that?
I don't know that the science that it actually helps tumors. I mean, the basic science makes sense, but in reality, in clinical practice, I've never seen that be of great value. And when you put people on low carb diets, by definition, you put them on high protein diets. So if they have any degree of kidney disease or risk for kidney disease, then they're just harming themselves without necessarily getting any proven benefit. Again, individualized conversation, have a dietitian to help supplement, but not entirely sure that there is a huge amount of science to support it. Well, there's also there is a chat and a question and answer. So I think we're good with the questions, Khalida.
I think we're good. We've answered most of the questions. I think we can go on for some time, but we promise to end at whatever time it is which is now in your time zone. And I'm just going to ask, I see as one of our participants is Professor Rasha Darwish, who is part of the AFRAN. She has her hand up, and she's part of the AFRAN executive and board, and she's our treasurer, actually. And I just ask Professor Darwish, since you're here, why don't you just give us a vote of thanks to all of our speakers, and lovely to have you on.
Thank you so much, Khalida. I mean, first of all, I enjoyed this webinar to an extent you cannot imagine. I just want to start to thank Dr. Berus, who, since we discussed the idea of having this collaboration, was extremely cooperative, him and all of his team, answering all of the emails and doing whatever is needed to make this happen. So thank you so much for that. And of course, I want to thank all the speakers, Dr. Mandayam, Dr. Oguchi, and of course, Wesley, and the amazing moderation that both of you and Pooja had. And I just want to suggest that after listening to these amazing presentation and discussions, that I think for our continent, what we could start working on is actually, what's actually affordable is nutrition, because I don't think that the advanced chemotherapeutics are kind of available in many of the African countries. And actually just adjusting maybe a protocol for what is a suitable nutrition according to each region's major type of nutrition could be a start. If you could have a guideline targeting this, especially of the amazing conversation and topics, I think that's where we could start. And please, let's have more and more webinars and more collaboration, because I think we have a lot to learn from you. And we're hoping that you also have things to learn from our region and our pathologies in onconephrology.
Absolutely, and I'm more than happy to collaborate. If anybody is interested on that side, I can get my dietitians to come put together a framework of a diet that we won't know all the regions. So obviously we'll need people from each region to come help us figure out how to make this happen. But it's a great, simple, practical tool that we can disseminate across, where we do a standard structured diet with various ingredients and adapt it to your individual locations. Wonderful.
So Dr. Pooja is, thank you for those comments, Dr. Darwish, Dr. Rasha. So, but Dr. Pooja is developing a patient guide for hyponatremia that will be published by the American Society of Onconephrology, which will be a handy tool that everyone can use in their clinics. And perhaps we can co-develop something based on the best level of evidence. There's not a lot of evidence, as Dr. Mandayam pointed out, but to the best of our knowledge, what a good cancer diet would be. And so maybe that would be a great joint project that we can publish.
Amazing. So we have a point to start. Yes.
This is a great conclusion to this, and another wonderful collaboration come up, and I'm sure we're going to get it done. Professor Darwish, the email threads continue.
Perfect. Let's continue.
And I
thank you all. It was amazing. It was amazing, really.
Was also very much part of this, and it's just that she was busy today when we changed the dates of the conference. So she's was very, very integral to this. Yeah. I guess it is now 9:03 p.m. in Nairobi, and everybody should go out and enjoy their day or their evening after, and a lot to think about. Thank you so much, everybody, and thank you to our participants for staying with us up to the end, the insightful questions and the comments, and we hope that this has started a thought process and collaborations that will continue to ensue. Have a great evening.
Thank you, everyone. Have a great evening. Thank you.
Thank you.